Good to have you back, Carrie. We missed you.
Good morning. Yes, we are all set to start.
Thank you. Just counting the members here. Looks like we're all set. Good morning and welcome to the morning session of the Joint Standing Committee on Health and Human Services. It is Thursday, the 13th of May, and we are assembled around our virtual horseshoe live streamed on the HHS channel found on the Maine State Legislature's YouTube channel, where you can find the replay of our proceedings should you miss us live. On our busy morning agenda, we will have a presentation from the Department of Corrections Deputy Commissioner Ryan Thornell on medication-assisted treatment to begin our morning, and then we will move into work sessions, beginning with LD 38 and 1090. And then I will regroup and let everyone know what the order of the rest of the morning will entail. So we'll start with some introductions of the committee, beginning with Representative Zager.
Thank you, Madam Chair. Good morning, everyone. I'm Sam Zager. I represent District 41 in Portland.
And Representative Lemelin.
Good morning, everyone. I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
And Senator Baldacci, I am not seeing. Representative Connor is in his other committee. Representative Craven.
Thank you, Madam Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
And Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescay.
And Senator Moore.
Good morning. Representative Madigan, it's great to see you back. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
And I am Representative Michelle. Oh, I'm sorry, Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
My apology for nearly forgetting you. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, and parts of Kittery and South Berwick. With that, we would welcome Deputy Commissioner Ryan Thornell. Nice to see you here this morning.
Thank you, Madam Chair. So good morning, Representative Meyer and distinguished members of the Joint Standing Committee on Health and Human Services. I am Ryan Thornell, and I serve as the Deputy Commissioner of the Maine Department of Corrections. It's a pleasure to be here this morning with you. And the purpose of me being here really is to provide the committee with just a brief presentation of information about the Department of Corrections medication-assisted treatment services, which are offered across all of our state correctional facilities. And given the recent discussion around MAT services and corrections, it's been a topic that has been debated and discussed in the communities and in the legislature. We hope this briefing will really provide a good overview of information, answer potential questions, and then certainly I'm available following the presentation of information to take more specific questions. So with that, I'll just dive in if everybody is ready to go. So the Department of Corrections currently provides medication-assisted treatment services at all 5 of our state correctional facilities. Those include secure housing facilities, but also our pre-release work release facilities. And we currently have more than 300 residents receiving MAT services on any given day. That's roughly 19% of our total population within the Department of Corrections. Residents coming into the Department of Corrections currently receiving medication-assisted treatment services prior to incarceration or prior to their time with us, maybe in the county jail, are able to be continued on MAT from the moment they come through our doors, which ensures a continuity of care either from the community or from the jail. And we also have the ability to look back if somebody does come to us potentially just completing a period of withdrawal or tapering off medication for whatever reason it may be. We are active in the prescription monitoring program, and we have the ability to look back at prescribing practices in the recent past in order to see if it's medically appropriate to continue to start somebody and continue them upon admission into our facility. Additionally, residents who are not currently receiving medication-assisted treatment services while they're with us, but are within 2 years of their release from incarceration, are eligible for MAT induction. This current mark of 2 years to release was recently expanded, and we will be further expanding that eligibility criteria in the coming months to universal access. So we will be reaching a point this summer where every individual that's incarcerated in our Department of Corrections, regardless of their time to release, will be eligible for medication-assisted treatment services. And I'll just remind the committee, some of you were on the committee and met with us several years ago when we launched medication-assisted treatment as a pilot program. At that time, it was only open to those within 6 months of release. And so we've dramatically expanded that eligibility. And again, we're excited that this year, 2021, it will be universally accessible. Residents who are deemed eligible for medication-assisted treatment within our department are identified through a few different processes. And I just want to briefly outline how that might occur. First, they may be identified upon intake into our facility, as I mentioned, either coming from the community, but most likely coming from a county jail, at which time we would verify their prescription, their medical services from the county jail or a community provider and continue them with services. If that's not the case, they can also be identified upon referral from a clinician to a medical provider. So it may be that they're seeing a behavioral health clinician in our facilities, and through that clinical interaction, the clinician may make that referral to medical services for an assessment and potential induction into MAT. Residents are also able to submit what's called a sit call request or a medical services request form that goes to our medical providers and is reviewed. And they themselves can advocate for an appointment and evaluation with a medical provider for induction. And so following that one of those processes, the resident would be assessed. If they have not already been, they would be assessed by a clinician for substance use disorder or opioid use disorder. And if meeting one of those criteria, they would then be referred to a medical provider for further review and evaluation. And it's that interaction and review with the medical provider, between the provider and resident, that ultimately results in the decision to be inducted into medication-assisted treatment. And that's an important point to note, because our position on MAT in corrections is that it's a medical process, it's a medical necessity. And so we leave that decision up to the medical provider. It is not something that our general operations staff or facility staff make the decision on. It's strictly between the medical provider and the individual resident. And during that conversation where that decision is made, the provider and the resident at that time would review the various treatment options that are available, the various medications that are available, and jointly determine which is the most appropriate path forward. And they may take into account past medication practices, medical services, successes, and shortfalls. They may take into account where the individual is releasing to, knowing what services may or may not be available for continuity of care. They take into account all of those different options. Medications that are available for use with MAT within the Department of Corrections include buprenorphine, methadone, which currently is available upon continuation into the Department of Corrections from the community. And we're actively putting in place methadone services for further expansion. If you're familiar with methadone in correctional facilities, it has a different set of regulations and compliance standards that we're working through right now, different than buprenorphine and some of the other medications. We also offer 2 long-acting injectables, naltrexone being one of them and Sublocade being the second. So perhaps the most critical aspect of all of medication-assisted treatment services inside corrections is really the continuity of care process for the release of a resident into the community. And I say that's the most critical because having a strong continuity of care from incarceration into the community really mitigates the very high risk that these individuals leave the facilities with, high risk for overdose. And so we put a lot of resource, a lot of staff resource and attention into that continuity of care process to ensure that individuals leaving on MAT and in need of MAT have what they need immediately upon release into the community. And so we do that by partnering with groups Recover Together and Day One in different parts of the state to provide continuity of care services as these individuals near release. And what that entails, it includes obviously a referral process to a community provider. It also entails assessment processes and appointment scheduling. And our appointment scheduling is completed in a fashion that allows for rapid intakes into MAT services in the community. And our goal is to have an appointment in place for an individual within 72 hours of their release. And so we don't want them going any more than that 3-day period before seeing a clinician in the community and continuing that care with a provider. And we're very successful at that. And our partnerships with groups Recover Together and Day One really allow for that. And it gives us access to statewide resources, because as you all know, leaving the Department of Corrections, individuals released to all corners of the state of Maine. And so having broad access to those appointments and services is critically important. As part of that release continuity of care process, individuals receiving MAT services also receive training related to naloxone usage or Narcan usage. And they receive information and training on its role in the treatment and recovery process. And at the time of release, they also receive a Narcan kit that they take with them upon release into the community. And we've been having that process in place since we started MAT in 2019. And we're very proud of that partnership as a harm reduction method for individuals releasing into the community. They also receive a smartphone upon release, and the importance of the smartphone has been demonstrated during the pandemic, because most MAT services in the community have resulted in treatment services being provided virtually. And so individuals leaving with a smartphone are able to meet with their provider and clinicians in the community virtually. So there's not a disruption in service upon release. And then obviously they also receive a medication script to bridge the period between release and that provider appointment. And so if that appointment is in 2 days, they would receive a bridge script for those 2 days. If it's 3 days, they would receive it, and so on. We want to make sure that they leave with the tools they need to get to their community appointment and continue their services. And all of those services are in addition to the reentry case management services that we provide to every DOC resident, whether they're involved in MAT or not, which includes other housing assistance and other resource assistance. In 2019, as Governor Mills expanded Medicaid access across the state of Maine, the Department of Corrections, we were able to partner with the Office of Maine Care early on in 2019, and that has allowed us to ensure eligible residents who are releasing from our correctional facilities have Medicaid benefits in place and active the day of release. And that entails benefit coverage for a majority of the population releasing from our facilities. Roughly 95% of those individuals leaving from incarceration to the communities are eligible in some manner for Medicaid benefits. And if you're familiar with corrections prior to 2019 and this Medicaid Maine Care partnership, there was previously a 2-week wait period for those benefits to be activated and put in place. So having those benefits in place the day of release significantly enhances that transition process and the services that are available to the men and women releasing. To date, since we began our MAT services in 2019, we have released 674 men and women who have participated in the services and transitioned into the community. If you like numbers, the breakdown of that is 566 men, 108 women who have released. And in addition to the specific MAT services I just covered, I want to share with you real briefly that we also offer residential and comprehensive substance use disorder treatment services in addition to medication assisted treatment. And that's important because I want to share with you just a few data points. 35% of the male intakes that came into the Department of Corrections in the last year, 2020, were for a primary offense involving drugs. So that's more than 1/3 of the male intakes coming into our facilities were primarily there for a primary offense involving drugs. 58% of the female intakes coming into our facility were for a primary offense involving drugs. And when we assess them upon admission into our facilities, more than 75% of the men and women coming in are evaluated and assessed as needing some level of substance use treatment based upon their past history and their needs. And so because of that, we offer, in addition to MAT, we offer residential substance use treatment services across all of our facilities. We offer outpatient level of substance use treatment services and individual counseling services. And so that opens up an array of treatment services that either complement those who are receiving medication assisted treatment. And for those who may not be deemed medically necessary or eligible for MAT, it also provides SUD treatment services for that population. So we don't have a male or female in our system that doesn't have a service level available to them, which is important. We also offer treatment and counseling services through our tablet programs that some of you have been able to see when you've visited our facilities in the past. And these services on the tablets really serve as a supplement to the treatment services I just outlined. And we also make available peer recovery coaching, AA and NA across all of our sites. And then the last point I just want to make is it's important to note that we are also making great strides in our efforts in the department to destigmatize substance use disorder and opioid use disorder, as well as incarceration in general. In the last year, we launched an initiative that we refer to as Language Matters. And it is an initiative across the entire department where we are pushing to break down the stigma that's associated with being incarcerated and all of the needs and risk factors that come with incarceration. And that includes stigma that's associated with our staff and our residents. And so I just want to draw attention to that because I think MAT is a topic, substance use treatment is a topic, but language matters, and the destigmatization of all of those components complements and in some ways parallels this specific topic. So I wanted to make mention of that. And so with that, I'll just say thank you for the opportunity to share that information with you. I know it was brief and maybe a lot of information in a short amount of time, But I'm happy to answer questions or whatever the committee may further request.
Thank you, Deputy Commissioner. Questions from the committee? Yes, Representative Zager.
Thank you very much, Madam Chair. Deputy Commissioner Thornell, thank you so much. Really terrific presentation, and I salute the department's efforts. I know this takes a lot of stewardship and attention to detail, so I appreciate all of that. You outlined a really comprehensive package of the things that can kind of get in the way, the stumbling blocks that can occur. One question I have, you touched on, is regarding access to healthcare. Having the appointment you've rightly identified as a key step. Would you say that 100% of people who are being released have access to have health insurance, either through main care or some other way, and if not, what do you think the barriers are?
Great question, Representative. Thank you for that. What I can say is that we work with 100% of our residents to try to establish or shore up health insurance access for them. Each situation is different, and some have complexities. Those who are eligible for Medicaid that we work with the Office of Main Care with, I can confidently say to you that 100% of those eligible have benefits in place the day of release. And that is the result of the partnership we have with the Office of Main Care. That is roughly 95% of our releasing population that qualifies for some level of Medicaid benefit coverage. The remaining 5% or so are some of the more complex situations. And some of the factors that we work through and work with the resident on is, for example, individuals who are in our work release settings who have full-time employment may be eligible for benefits through their employer. And so we work with them to ensure those benefits are in place upon transition. And they may still have some eligibility for reduced Medicaid coverage, and we still ensure that is in place as well. And so those cases are often what make up that 5%, those who are currently working or perhaps have private insurance through some other means awaiting them in the community. But like I said, it's a very small percentage.
Thank you. And veterans, the VA, is that significant?
So another great question. Thank you. So we have a veterans pod at the Maine State Prison that specifically focuses on past service members and provides them with one housing area to make sure they have the veteran specific resources to meet the needs of that population. And we have a very strong partnership with the Veterans Administration, but also other local veterans community groups and resources. And so we ensure they have the benefits. If they have access to veterans benefits, military service time benefits, we ensure those are continued, or we help them establish access to those prior to release.
Thank you, Deputy Commissioner. Thank you, Madam Chair.
Representative Stover.
Good morning, and thank you for such a fabulous presentation. I think I've seen part of it once before correction at the committee, so it's great to see you again. I have a work session this morning on LD 1487, which you may be aware of, and it is to ensure availability of injectables prior to release from incarceration. And you spoke to injectables being available at the state prisons facilities, correct?
Yes, that is correct, Representative.
And how long has that been available, injectables?
So we have had long-acting injectables available since we launched our MAT pilot program in 2019 with Vivitrol, naltrexone being the injectable available at that time. And then I would have to go back and get you the exact date, but it was in early 2020, where we had everything in place and the access and availability of Sublocade. And so that came on later than Vivitrol.
Thank you. And a second part to that, I know that the Department of Corrections oversees the jail standards. And do you participate in the MAP programs for the jails in sort of an oversight position?
So we provide what I would refer to as technical assistance to the jails in their specifically in their medication assisted treatment services. We work closely with the Office of Behavioral Health in supporting their work, specifically with the county jails. But the day-to-day operations and treatment services provided in each individual jail really falls to the authority of the jail administrator and the county sheriff. And we provide more of that technical assistance role. And as you noted, there is now a jail standard related to medication assisted treatment that is very recent. And we're still working through the application of that and what that may look like in terms of the biannual inspection and compliance process.
Thank you. May I have one more question?
Certainly.
Just to add to that, selfishly, since we are doing the work session this morning, if injectables are offered at the state prison, how are those paid for?
So if they are offered while somebody is still in our custody, they're paid for through our general fund medical services contract and budget, just like any other medication is paid for.
Okay, thank you.
Thank you.
Senator Moore.
I think Representative Stover was thinking the same thing I was about the county jails. This is wow. I'm so impressed on how great this program has developed from when we took our little tour, and it was just those handful of guys that were on the MAT. This is great. It really, really is great. And I know this is not your bailiwick, but do we know how many of the county jails are actually offering MAT?
Well, thank you, Senator, and thank you for your ongoing support and comments. I remember that visit vividly. It was a great visit. So we do know that a majority of the county jails are offering medication-assisted treatment services, and I believe that all county jails are offering access to medication-assisted treatment. And I say access because I do believe that some of our smaller jails may be partnering with other jails to shuffle residents around. If they may not be able to have access in a smaller jail, they may swap residents in order to provide access in another area. But I do know they all are making efforts to make it accessible, but I believe they all have some level of access in place.
That's great. Good. Thank you so much. Appreciate that.
Thank you.
Representative Craven.
Thank you, Madam Chair. Yes, thank you for being here and for the great presentation. But we still hear about a lot of overdose and a lot of deaths in the community after somebody's been released. And maybe you could talk about that a bit and elaborate why you think that's still happening.
Yes, thank you, Representative. An unfortunate topic, but a very important one. I think that we're doing everything we can from a correction standpoint and a continuity of care standpoint to support that transition into the community. But it is unfortunate that the transition only covers so much. I will say that annually and now quarterly, we receive information related to the overdose deaths that are occurring in our communities, and we're able to compare that against prior Department of Corrections involvement and specifically medication-assisted treatment involvement in order to learn lessons of what was effective or not so effective in those situations. And what we find by far is that the compliance with arriving at first appointment and arriving at second appointment really play the critical factors in sustainable continuity of treatment in the community. And what I mean by that is the higher the rate of attending treatment, we see resulting in the higher rate of success, effective outcome. And when we look at the overdose deaths that may have participated in medication-assisted treatment services with us, because there were a few in 2020, when we look at those, we see that they're individuals who likely did not attend their first appointment. They did not continue with the plan that was put in place. And so, again, we do everything we can. The cases that have probation supervision in place upon release also help, because when there's probation supervision in place, that provides an added level of follow-up that the department can do to ensure that individual makes it to treatment and continues in treatment. But unfortunately, that's not always the case. Roughly half of the releases that release into the community, probation does not have any involvement in. But again, that time to and compliance with first and second appointment are really critical factors in the early success upon release.
Thank you.
Thank you.
Representative Madigan.
Thank you, Madam Chair. I would like some information more about the county jails, and I think Sheriff Morton is waiting. If we could hear from him about that, how it's being implemented in the county jails.
Certainly. I'm not seeing Sheriff Morton. Oh, here he is. That's because he's already here. Welcome, Sheriff Morton.
Good morning.
Nice to see you, sir. Thank you for being here. There's a question from Representative Madigan.
Yes, I was just wondering if you could speak to how all this is being implemented in the county jails.
Certainly, I'll try to do that. Obviously wasn't prepared. I was waiting for 1487 to be heard. Director Thornell has done a tremendous job kind of outlining some of the remarkable efforts that have been made in MAT. Another example of how both state and county corrections have evolved over the years. Penobscot, the director may have mentioned that Penobscot was one of the very first MAT programs in our state with the use of Vivitrol. Those were early on trying to proof of concept. We saw early on there was some benefits to having MATs in the county jails. But something that's really important, and the director mentioned too, that while county and state facility corrections are very similar, we're also very different. And the reason I say that we're different is if you look at a county jail, that we are taking people that are walking in off the street in crisis, sometimes often under the influence at that moment. And I often compare us to the EDs of any hospital where people are in crisis. I use an example. We modified our screening approaches for both issues such as, are you a veteran? Were you a veteran? Are you homeless? Have you been receiving mental health counseling? We've adjusted those intake screening tools, which included MAT. Are you currently receiving or have you received MAT services? Those are crucial. Here's something that we found. An individual just arrested, brought in sometimes in crisis, sat down and is asked that question. We received in a response, out of all of the people that we had surveyed, about 23% indicated that they had received MAT treatment or that they had an opiate addiction or substance use disorder. And to be quite frank, and being in this job for 30 years, I didn't believe that number. That seemed incredibly low to me. And so interestingly enough, when medical asked the very same question hours later, the number was closer to 49%. And what does that tell you? Somebody who is in crisis, who is now being booked within moments, maybe an hour of being brought into the jail and sitting down with somebody in uniform to talk about medical and mental health information, may not be sharing always accurate information. But yet in a situation where they were being interviewed by a medical provider and they feel safe and have an opportunity to be able to share some of that personal information was critical to our process. So we've learned an awful lot as we go along. I think the question the representative brought forward, and thank you for including the counties in this important discussion, is that majority of the jails do have comprehensive plans in place. And that while some are very resource rich in areas, some are smaller county jails are relying on other counties to assist them or the state. And in some cases, they were providing services from outside providers to come in. One of the areas that we're fortunate that we have a provider in the facility at all times. We have about 12 individuals in the program right now. Last year, we served over 90 individuals in our MAT program in the jail. The director and myself and an incredible panel worked for a long time on model policies that we were trying to make sure that what we start at a county jail level has to essentially mirror what MDOC has in place. If we're moving individuals or stabilizing an individual at a county jail level, and if for some reason they are sentenced and move on to MDOC, we want to make sure that those are similar practices. And I think we're very close at doing that. We continue to learn. We're finding that methadone has been a challenge. The director made a great point. So it's different providers, it's different processes. And so how do we continue on with those that are there? We also see, to be quite frank, a difference in opinions by providers. One doctor believes treatment this way, another believes this medication or whatnot. So I think that one of the greatest things that corrections does is we've tried to remove ourselves from that process so that these are not correctional decisions. These are medical decisions. These are treatment decisions. And I think that's critical. We don't punish people by taking them in and out of a program because they're not, because they're misbehaving or they've failed, right? We know that there are many pathways to recovery. I think somebody asked the question, why are there still so many overdoses in the community? Well, there are many pathways to recovery. There's not just one way to get there. So I'm probably going on way too long, and but it's something I'm passionate about because we've all been directly affected by substance use disorder in one form or another. I do believe, and I strongly believe, while jail is not the place for treatment, I do believe that if we have that opportunity to plant a seed and put somebody towards one of those pathways of recovery, we need to do it. But somebody mentioned cost. Many of the county jails are grant funded to run these programs. And that's great. The Office of Behavioral Health has been tremendous in supporting us through that, but we cannot sustain and live on grant funding, unsure of what the next step's going to be, whether the funding continues or not. So long-term sustainable funding is critical, making sure that we can mirror our model policies with the state, find those services that work. Somebody asked about the follow-up on somebody leaving. That has been one of the most heartbreaking problems that I see. We set up program after program, step after step. Folks, whether you believe in the incarceration or not, some people get on that pathway to recovery here. Medical treatments, educational treatments, self-worth, all of those things are built in. And when they are released, even if we're setting up great program, we have what we call the Bridge Project here in Penobscot County with PCHC. Many people will not take that step to go to that appointment when they leave. That's a fact. And so we've got to figure out how can we continue that work that they've done and the support that we've provided to them. How do we get them to continue to do that? And lastly, on a positive note, we have seen, though, that it is effective when people respond to those treatments. PCHC reported to me, Sheriff, that in a year's period of time, in running our first program, the Vivitrol program, not one single person in that program overdosed upon release. That was powerful. And that was a proof of concept that this can work. And so, but it's complex, and it's even more complex in a county jail systems. We often hear the stories, I've heard some of them in your committee and CJ this year, where they were taken off the program. They weren't offered a MAP program that they had on the outside. And when they came to jail, it was all stripped away. The truth is, when we get into the weeds, some of those individuals hadn't participated in those programs months before coming to jail because they fell off their pathway to recovery. And sometimes our job is to help stabilize them back. So again, I'm sorry for going on so long. It's something I'm passionate about. It impacts us all in our communities. I'm happy to answer any questions. I appreciate truly the directors continue to support. I feel like we're in this together. And while our missions are a little bit different with new arrests versus long-term, I think our missions are in alignment.
Thank you, Sheriff. Seeing no other hands up, we want to thank Deputy Commissioner Thornell and Sheriff Morton for being here today
Thank you.
and for the work that you do.
Thank you.
Thank you, gentlemen. So I want to give an opportunity to Senator Baldacci and Senator Claxton to introduce themselves.
Thank you, Madam Chair. I'm Joe Baldacci. I represent State Senate District 9, which is the city of Bangor and the town of Herman. Good morning.
Morning.
Thank you, Representative Meyer. My name is Ned Claxton, and I'm honored to represent the folks in Senate District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester.
Thank you, sir. So as advertised, we are going to begin a morning agenda filled with work sessions. We will be beginning with 38, followed by 1090, then 869, 1603, 1487, 1653, and 196, 197, and 674. With that, I would open the work session on LD 38 and say good morning to our analyst, Erin Dooling, who I failed to have introduce herself this morning. So please go right ahead and do that.
It's no problem. Good morning. My name is Erin Dooling. I'm one of the legislative analysts with the Office of Policy and Legal Analysis. And we provide nonpartisan information and aren't taking positions on any of the bills before you.
I'll also ask Carrie Withy, our clerk, to introduce herself.
Good morning. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance today, you can email me at hhs@legislature.maine.gov.
Thank you. So I will turn it over to Erin Dooling.
All right, LD 38 is an act to clarify the timing of an appeal of a finding regarding involuntary mental health treatment at a designated non-state mental health institution. This bill amends the process governing the request for review by the commissioner of an order of clinical review panel regarding involuntary mental health treatment. It provides that the commissioner or the commissioner's designee must review a decision of the clinical review panel for abuse of discretion, error of law, or findings not supported by substantial evidence in the record. It extends the deadline for the commissioner to review a final decision to 4 business days after the submission of the record and any arguments, establishes a deadline of 3 business days for a designated non-state psychiatric institution to submit the record to the department, establishes a deadline of 3 business days for the submission of written arguments by the patient and the institution. You had a couple of questions at the public hearing about, one of them was about when will a clinical examiner be hired in Bangor. I received information from Julie Finn at the Judicial Branch that in April, we added an independent examiner for Bangor civil commitment and treatment over objection cases for both Acadia and Dorothea Dix hospitals. And the new examiner mentioned in that email is a nurse practitioner. There was also a question about why there seemed to be a recent uptick in these types of cases recently. I don't know if anybody had any kind of definitive answer. The information that I received back was perhaps this is a COVID-related bump. The preliminary fiscal impact statement identifies no fiscal impact. And oh, that's it. That's it on this one.
Thank you. We are also joined this morning by Assistant Attorney General Molly Moynihan, sorry about that, who I can see has been brought over, but here she comes. Welcome. Nice to see you. And thank you for being here today to help us work through LDs 38 and 1090. So following Erin's analysis, I would ask the committee if they've got any questions, thoughts regarding LD 38. This is a department bill introduced to us by Senator Claxton.
And the intent is to clarify some of the expectations in the review process, to define some timeframes. We had a pretty good conversation the first time through. It was tabled pending some better understanding of when there might be an independent examiner for the northern region. And according to the document that we just saw, that happened in April. So I would have a question for Lisa Harvey McPherson about whether that process has started. And that would be pretty much the extent of my questions at this point. Thank you.
Yeah. Good morning, everyone. Lisa Harvey McPherson with Northern Light Health, and I'm speaking on behalf of Northern Light Acadia Hospital. This spring, an independent examiner was provided to Acadia Hospital. It is a nurse practitioner, as Erin mentioned, and it's the same examiner that is available to Spring Harbor. The assessments are done via telehealth technology. The bill was actually prompted, I believe, in part by the fact that there wasn't an independent examiner in the northern region. So Acadia Hospital set up a medication review panel to make recommendations on medications for involuntary treatment, and that went through a process up through to the commissioner's office. That prompted the bill. So now we have the same examiner that's available in Southern Maine, and that brings the process back over to the judicial branch.
And then also a clarification from Attorney Moynihan about the timelines in the bill. Is the department AG's office comfortable with the timelines as lined up in this departmental bill?
Yes, good morning, everybody. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. Our office, I'm here on behalf of DHHS as legal counsel and to answer any questions in general about how these statutes work, both on the district court side for involuntary treatment and on the clinical review panel process. Our office, the Attorney General's office, is not taking any position on any of the policy considerations at stake with this bill and would defer to DHHS for any of those questions.
Thank you.
You're welcome.
Yes, Senator Moore.
So I guess that raises the question of, do we even need this bill any longer? It sounds like as a result of, now that we actually have someone that is available as an independent examiner, that we may not need this bill any longer. Am I understanding this correctly?
Yes, Senator Claxton.
I think we've addressed the issue of the lack of an independent examiner has been fixed. That was raised during the course of the discussion of the bill. What the bill does is also define the expectations better of what the department's responsibility is. And its responsibility changes with this legislation, and it's an important distinction because it's the difference between conducting a de novo hearing or reviewing what's been done so far for any missteps. I may have not done an adequate job of that, but I defer to Molly and to Attorney Moynihan for clarifying. But I do think the bill has some elements that are very important, and the independent examiner piece wasn't even part of the original bill.
Molly Bogart.
Thanks. I'm Molly Bogart, Director of Government Relations for the department, and it might be helpful also to have our Chief Administrative Hearings Officer. I know there's a Joe and a Joseph Pickering. I believe it's Joseph Pickering in the attendee list, who is our Chief Administrative Hearing Officer, and he can talk about the standard of review that we are looking to change here, and also the the reason for bringing this bill forward.
Yeah, I see Mr. Pickering has arrived. Welcome.
Yes, thank you. Thank you for letting me join. As mentioned, my name is Joseph Pickering, Chief Administrative Hearing Officer for DHHS. And I'm happy to answer any questions. In regards to the earlier question, do we still need this bill? And I think the answer is yes, for a couple of reasons. Right now, the statute allows for two processes for allowing the involuntary administration of psychiatric medication to involuntary patients. One is through the district court process, which is what we were talking about earlier with the independent medical examiner. And then the other process is the clinical review panel process for patients who have been involuntarily admitted where the district court, for whatever reason, didn't address that issue. And that's really what this bill is about, is for that second process. There's always going to be potential situations where a hospital might need to do a clinical review panel. There could be a situation where, they're no longer able to have the independent medical examiner, or perhaps the independent medical examiner is just not available, or there are other hospitals that are not in the Bangor region that might be choosing to end up using the clinical review panel process. And so under those scenarios, we're going to be back into kind of the same concerns that we talked about at the initial session about the some confusion about the process and just the incredibly tight deadlines. And so I hope that answers the question.
Thank you, Mr. Pickering. Yes, Lisa Harvey McPherson from Northern Light.
Two points of information that I think will be helpful for the committee. My understanding is that there's one examiner, and we're grateful to have certainly the assistance in the Bangor area. We do wonder if that is enough to ensure the access that's needed to the examinations. If the examiner, for example, were fortunate to win the lottery, perhaps they might make a different choice. And so it would be helpful if we are going to kind of have this dual process continue, which it will, to understand from the judicial branch, do we have enough examiners to meet the current needs securely? I think that would be important information for this committee to have, and perhaps a letter could accomplish that. Regarding the timelines that are in the bill, just a brief refresher. The early timelines we agree with, having an individual who's involuntarily hospitalized, wanting representation for a determination of involuntary medication. That individual will need some time, and we think 3 days, as outlined in the bill, is reasonable. Where we had discussion that was different from the perspective of the department was allowing the commissioner or her designee up to 4 days to make a final decision. We feel that that could be tightened up because once all of the information is presented, the case is pretty clear, and we really have to question why the patient has to remain hospitalized for another 4 days with no treatment for a decision to be made. So I think that is the issue where we have a perspective and the department has a different perspective.
Senator Baldacci.
Thank you, Madam Chair. One, I appreciate Mr. Pickering's contributions and his work. I do think that we still need this bill in toto, because first of all, Bangor is not northern Maine, and it is central Maine, but in any event, there is an overwhelming need for these examiners. And so I would want to still have the committee consider making sure we have enough capacity, that's all. But I think this is a good bill, it's a helpful bill, and appreciate the sponsor working on this because it is an important issue. Thank you.
Yes, Molly.
Thanks. I'm wondering if Mr. Pickering could speak about the length of time that is required for the commissioner's office review, even under this proposed standard.
Thank you again. So in terms of what the hospital was mentioning about the 4 days and what I'll call the close of the record, the receipt of the record, what I want you to think about in terms of, when we're coming up with this decision, is that when we're reviewing a clinical review panel decision, so you have medical records, you also have a recording of the actual clinical review panel. And that, usually takes about an hour out to an hour and a half, could be up to 2 hours. So when you think about the process, we've received the appeal, we've received the record, we've received the arguments from the hospital and the patient, and the bill currently says that the commissioner or the commissioner's designee now has 4 business days to issue a decision. So within that 4 business days, you have to review the medical records, review the arguments, watch or listen to the clinical review panel recording, write the decision, and then normally what we're doing is we're making recommendations to the commissioner, and the commissioner is making the final decision. And then we have to send that up to the commissioner, and the commissioner then has the opportunity to review it. I think it could be short. I think it could be tightened up a little bit. I would certainly think that 3 business days would be doable. I think going shorter than that creates problems. If we were to go down to something like 2 business days, we're again having to move very quickly from when we've gotten everything in terms of moving forward. And there are times when we disagree with the hospital in terms of whether or not they've actually followed all the necessary procedures. So it's not a question of just checking off a box and saying, yes, the hospital did it right. Sometimes we've actually found that the hospital did not do it right, and they had to go back and do the process again, because these are obviously very important procedures that we follow. Thank you.
Thank you. So that would, go ahead, Senator Claxton.
Thank you. I'd certainly accept the 3 days, but I would defer to, sounds like Molly and the team could live with that. I'd accept that as a friendly amendment. And I think the issue of capacity was raised in the course of the hearing and is best addressed by a letter and is not currently part of the bill, and I prefer to leave it that way.
Thank you, Senator. Yes, Senator Moore.
Thank you, Representative Meyer. In view of all of our discussions, I'm going to make the motion of ought to pass as amended on LD 38.
So just to clarify the as amended, that would be a return to where it presently is, the final decision at 3 business days. And a letter with regard to the number of examiners.
I second that.
So we have a motion and a second to pass as amended. Any further discussion? Seeing none. Ms. Withy, please call the vote.
Representative Zager. Representative Zager is absent. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you. With that, we will move to, oh, I'm sorry, Erin, go ahead.
That's okay. I just have a question about the letter. Are you just asking the judicial branch to assess its capacity? Or are you asking them to increase its capacity? What exactly should be contained in the letter?
I'll turn to Senator Claxton for what he'd like to see in that letter. I'd also ask Ms. Harvey McPherson, just to elaborate a bit more on your recommendation for what the committee would be asking in the letter.
Yeah, thank you. My understanding is there is just one examiner. So if the letter could inquire to the current number of examiners, the projected volume of examinations, and the number of examiners that would be needed to really ensure consistent access.
Senator Claxton?
And I was thinking along the similar lines, just to say that in the course of hearing this bill, the issue of capacity was raised. And could the judiciary look at assessing whether we have adequate capacity the way things are set up? And by my understanding, we have no backup plan. So both of those should be elements for a letter, included in the letter.
Thank you. Moving on to LD 1090.
LD 1090 is a resolve to equitably fund legal fees for progressive treatment programs. It establishes a pilot project within the department to fund court and legal fees incurred by superintendent or chief administrative officer of a non-state mental health institution or a director of an ACT team in association with filing and obtaining an order from the district court to admit a patient to a progressive treatment program. Pilot project is to be funded up to $250,000 from the medical use of marijuana fund to provide up to $800 per application. And it requires the department to submit a report to this committee at the conclusion of the pilot project, and the committee would be authorized to report out legislation. You received some suggested amendments and issues raised at the public hearing, including that the bill as drafted does not provide financial support to other individuals who are authorized by statute to apply for a progressive treatment program, including a medical practitioner, a law enforcement officer, or the legal guardian of the patient. You also received a request to include a requirement for data collection about patients enrolled in the progressive treatment program, and to solicit surveys from patients, family members, and community providers. A drafting question note that I have is whether court and legal fees, which is what the project is intending to fund, is sufficiently clear. I did try to run down what court fees might be associated with this, and wasn't unable to really determine that. It doesn't appear that there's any kind of filing fee associated with submitting an application to the district court for a progressive treatment program. And the cost of the independent examiner, which is about $100 an hour, I think, is paid by the court system. So I'd be looking for clarification about what that means and whose legal fees and what's intended there. I also had a question about whether the timeline to begin the pilot project is sufficient. The resolve without an emergency takes effect 90 days after adjournment. If we assume an early July adjournment, the resolve will take effect sometime in early October, but the pilot project must be up and running by October 1, 2021. So whether that's enough time for it to be implemented, and relatedly, how the pilot project will be administered. Will DHHS need rulemaking authority to implement this pilot project and the reimbursement of the money related to the costs that are provided in the bill. You asked whether the Office of the Attorney General has input on this bill. AAG Molly Moynihan is here to speak about the bill, but also provide an overview of the process of the Progressive Treatment Program, if that's helpful to the committee. I provided the information the department has on the PTP on its website, which includes the forms that could be filed with district court. They're all available online. And the Disability Rights Maine created a guide outlining, hopefully in plain language, some of the laws relating to involuntary hospitalization and outpatient services. The PTP portion begins on page 23 of that PDF. And I know that Kevin Voivodich of DRM is available as well this morning if the committee has questions. And finally, because I thought somebody might ask whether the Medical Use and Marijuana Fund has sufficient funds, I did reach out to OFPR, and they provided that Excel spreadsheet table indicating the current balance for your information, and the fiscal impact hasn't yet been determined. And I do want to note that I will own any drafting errors on this bill. I drafted it. Please don't blame the revisor's office.
Thank you, Erin. Initial questions or discussion following the analysis, and then I think we'll go to AAG Moynihan to weigh in on 1090. Yes, bill's sponsor, Senator Claxton.
Could I just provide a little bit of context and some cover for Erin Dooling in the drafting, because she was working with somebody, me, who was totally unfamiliar with this area and stumbled into a lot more than I had originally signed up for. The intent of the bill basically is to begin to try and remove some barriers for the process of getting to a PTP hearing, such that practice can more closely replicate what's in the law, which specifically allows law enforcement people, medical practitioners, ACT teams to initiate the process of getting to a PTP hearing. So and my understanding was that the finances of that were a barrier. I have learned a lot. I learned a lot from a recent communication I read from Attorney Moynihan, and I continue to learn. So the overarching goal is to make it easier to get people into the PTP process without necessarily, in my mind, having to be hospitalized. So with that context, I'd love to hear from Attorney Moynihan, and I'm sure Joseph Pickering could help us if he's still available, or others in understanding and improving the process. Thank you.
Thank you, Senator. Attorney Moynihan, welcome.
Thank you, and good morning again, everybody. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on the Judiciary. Again, I'm Molly Moynihan. I'm an AAG at the Office of Attorney General, and my primary work centers on mental health. I am fairly familiar with the Title 34B provisions governing commitment, treatment, progressive treatment program. I appear regularly in the district courts on these matters on behalf of state agency clients. I am more than happy today to answer any kind of general questions, and also want to point out a few concerns from the AG's office on this bill. The first would be, and I don't know, Senator Claxton or Representative Meyer, whether it's better to do an overview first or to answer specific questions. An overview, okay.
Yeah.
I see a couple nodding heads. So the Progressive Treatment Program Plan is sometimes referred to as an outpatient treatment program. And what it allows is a series of different folks can apply for a patient's admission to the PTP. Most commonly in my office's experience, we see this as part of discharge planning from the hospitals. And so we have, this tool is presently utilized by both the two state hospitals, Riverview and Dorothea Dix. And a handful of the non-state hospitals are using this as a means of discharge planning to make sure an individualized plan is in place for the patient as they're leaving the hospital setting. As Senator Claxton pointed out, this bill or this current statute also enables plans to be created from the community. These are not instances that I'm familiar with. For example, I have not heard of a law enforcement agency creating a plan. I have heard of a rare occasion where an ACT team is creating a plan from the community. So it is possible. And I also wanted to point out that these plans at their core are individualized. So these plans would be designed to meet the patient's needs and could be as elaborate as including, weekly case management meetings, requirement to live in a group home setting, compliance with medication, meeting with a psychiatric provider once a month. Even sometimes there's an overlap with group homes and ACT team services. So they can be quite comprehensive and quite detailed, but the statute doesn't require that. They could be as simple as saying, this individual needs to comply with their medication in the community. So the amount of work that would go into developing these plans could vary. Another aspect of these plans is that they must be supported by licensed and qualified community providers who are there to support the plan. So again, that could be an ACT team, that could be a group home, that could be just a psychiatric provider. Sometimes is the only party named to the plan other than the individual. In terms of the application process, these are heard in district court and they're filed in district court. And I think one of the core issues that's kind of being debated with this bill is, well, what are the fees and that are required? Ms. Dooling represented that maybe there's no filing fees, and that's our office's understanding as well, is that the court doesn't require filing fees for these types of applications. Similarly, they wouldn't require a filing fee for a civil commitment application either. Again, the examiner is part of the process to evaluate these applications and report to the court, and that's a function of the court and a contract with the court. So the court is paying for those as well. And as Ms. Dooling represented, there's forms on the DHHS website. So these are already prescribed. The commissioner of DHHS has that authority to prescribe forms. And on the website would be the application, a certificate of medical practitioner, the patient notification form. So the packet of material that would be filed for these cases is already available. It's a form. The only thing, as I said earlier, that's not part of that packet or that would be need to be created would be the individualized treatment plan, and that would vary from case to case. I am not aware of any requirement in the statute that these applications be presented by legal counsel. There's nothing in Title 34B, Section 3873A that would require a non-state hospital, for example, to present these cases with an attorney present. That said, our office is appearing at these hearings on behalf of the two state hospitals because of the Attorney General's role in overseeing litigation for state agencies. And that's, of course, not to presume that folks know this, but that's part of Title V and Section 191, the requirement that the Attorney General is appearing on behalf of state agencies in civil actions. So that's, I can go over at hearing. What happens is that the patient is afforded a legal counsel. So the hearing would have an attorney appointed for the patient, and there would be the independent examiner who would be offering independent opinion on whether the individual is meeting the criteria for the PTP. And then the district court can make a decision on whether to approve the plan or not approve the plan. The time period is for a period of up to 1 year initially, and then the applicant or party to the plan can go back and ask for additional time through an extension. One thing I also noted in this LD is that this is this is just a smaller issue, but there, LD talks about funding applications. I did want to point out that once someone is on the PTP and in the community, that on occasion there's a need to file a motion with the district court, and this bill doesn't address who would be responsible for filing that motion or who funding that motion. Those motions can include motions to extend the plan for another year, or a motion to modify. Sometimes an individual, for example, who discharges from Riverview may be going to a group home, and 3 or 4 or 5 months into the plan, it's the parties realize and the outpatient providers recommend that maybe a less restrictive setting might be possible. So then the plan is brought back to the court to modify it and have a new living situation, for example. So that's kind of an overview. Does anybody have any specific questions or general questions about the process with the PTPs?
Senator Claxton. You're on mute, Senator.
I'm new to this process.
Mm.
The information about how this process works that you've provided helps me further understand it. Thank you, Attorney Moynihan, for being here and doing that. What about attorney's fees? Who's responsible for the fee for the patient or the client, depending on terminology? Who pays those?
I was looking, thank you, Senator, for the question. I was looking in the statute, and attorneys are appointed, just going back a few sections in the statute in the commitment cases. There is clear language in the civil commitment cases that attorneys are appointed for the patient and that those expenses are paid for by the district court. And that would be at section 386410, which is very clear that the counsel for the patient and the independent examiner are paid for by the court. That same provision doesn't appear in section 3873A. However, it is my understanding that those attorneys that are appointed for counsel are also paid for by the district court. The attorneys are coming off of the, for the most part, unless the patient selects his or her own attorney, they're coming off the roster for the MCILS attorneys.
Thank you for that. And a last clarifying one. You said these cases are heard in district courts, but I think I've recently learned that it's not all district courts. Is that accurate?
The progressive treatment program cases are all heard in district courts. The only process in Title 34B that is not part of the district courts, and this may be, Senator Claxton, what you're thinking of is that clinical review panel, which is the administrative procedure that occurs at hospitals. Okay. But the district court has jurisdiction over the PTP cases as they do the involuntary commitment cases.
And that part I understand, but I think I learned yesterday that the Lewiston District Court doesn't hear PTP hearings.
The jurisdiction where the Lewiston District Court may not have PTP cases on their docket because they may not have applications being filed in their jurisdiction. But yes, Lewiston would, as far as I know, would have jurisdiction over cases that are filed in their district court.
Okay. And one more indulgence from the chair, if I could. One of the experts here, Dr. Henry Skinner, might help with the experience of the local ACT team and speak to that. So if we could invite Dr. Skinner in at some point, he may be able to help with some of the questions. Thank you for those answers, Representative Moynihan. I'm, like I said, I'm still learning.
Thank you, Senator.
We'll bring over the doctor, and I don't see that Joseph Pickering is still here in the attendee list with us. There was another request. Yes, Erin.
If I could just jump in before we move on to a different topic.
Sure.
I did reach out to the Maine Commission on Indigent Legal Services and attorneys appointed to represent patients in those programs, not broken down by which program, but generally about mental health and release cases are paid $60 per hour for time spent.
Thank you. Dr. Skinner, welcome.
Thank you, Chairperson Meyer and Senator Claxton and members of the committee. My name is Henry Skinner. I reside in Yarmouth. I am the medical director at Tri-County Mental Health Services and the immediate past president of the Maine Association of Psychiatric Physicians. And I'm here to answer any questions you may have about this bill.
Thank you. Senator Claxton, you had a question for Dr. Skinner or wished for him to elaborate on the ACT team?
Yeah, and this is really all process question stuff, not content. And so, Dr. Skinner, what's your experience with initiating a request for PTP hearing out from Tri-County's ACT team?
To my knowledge, I've worked at Tri-County Mental Health Services since the summer of 2018, and we have not initiated a PTP from our ACT team.
And can you speak to how we might make that easier for your ACT team to initiate that, should you decide that was appropriate for an individual?
Yeah, there's a couple of things I can think of. One is the funding. ACT teams, as you've probably heard from testimony on other bills this session, ACT team funding is currently inadequate, and there isn't any funds for the agency's legal counsel to be reimbursed for the work that they would need to do. And the other thing is that, as you mentioned, the Androscoggin District Court we have asked them to renew some PTPs, to extend them, and they have refused to do so and refer us back to the Kennebec County District Court because their assertion is that since the PTP was originated by Riverview in that court, that court needs to hear the extension request.
Thank you.
Senator Moore.
Thank you, Representative Meyer. Attorney Moynihan, I'm probably going to butcher your last name, but I'm sorry. You started to tell us that you also had some concerns, or the AG's office had concerns about the bill. And I just was wondering if you would like to share those with us.
Yes, thank you, Senator. As Ms. Dooling pointed out, one of the questions that our office shares is that court and legal fees is not defined in this bill. And, you know, if it means provision of legal counsel, DHHS funding legal counsel for, you know, a non-state hospital or for an ACT team, that does raise some concerns. The first is that the department is not permitted under law to employ private counsel. DHHS can't retain its own private counsel, and that has to be approved through the AG's office. And that's all out of Title V, Section 191. That said, there are some sections of statute that I can think of where that is the case. For example, Title 15, Section 107 is a process to allow for involuntary treatment of individuals who are at a state hospital for competency restoration or for evaluation services, patients who are intersecting with the criminal justice system. So there is a hearing process, and that statute requires the department to fund counsel for patients as part of that process. And what that means is that the Attorney General's office has to approve contracts between DHHS and a legal organization to deliver those services to those patients. So in this case, if the intention of this bill is to have DHHS fund legal services for a agency, for a hospital or an ACT team, that would have to be approved by the AG's office. And that creates or results in some more questions. You know, when the AG's office does approve the Department of Health and Human Services to retain legal counsel, that involves a contract between DHHS and that legal counsel. DHHS is responsible then under the contract to review legal bills, to ensure that counsels remains within those caps. All of those fees are set by the Attorney General's office to approve those contracts. And I think where it starts to get a little challenging to think about is that currently there are non-state hospitals that are utilizing the PTP process. For example, Northern Lights Acadia fairly regularly, as far as I understand, submits PTP applications to the district court in Bangor. They do that through their own legal counsel, their internal legal counsel at Northern Lights Acadia. That person would present the case to the district court. And, you know, presumably that hospital has made the determination that it's within their budget and within their priorities to utilize this tool in the statute. So when it gets a little complicated, when, you know, if this bill is envisioning that DHHS fund legal services for a non-state hospital, for example, would there be a conflict arising between existing legal counsel for that hospital or for that ACT team and the counsel that is appointed or approved by the AG's office and funded by DHHS, you know, regarding who's representing the legal interests on these PTP applications? So basically that's, you know, some of the overarching concerns from the AG's office is this idea of DHHS funding legal counsel for these non-state organizations, having the Attorney General's office approve it. And, you know, would that create some conflicts with, you know, between different counsel and different interests?
Thank you, Attorney Moynihan. Senator Claxton, response to some of those
some
questions?
follow-up questions, and again, from a position of not knowing. You're representing the non-state hospitals now. I think there's 6 of them under a contract. Is that correct?
Thank you, Senator, for the question. It is not quite accurate. There are 8 designated non-state mental health institutions that are under contract with the Department of Health and Human Services. And the designated is defined in the statute in section 3801. So DHHS contracts with 8 non-state hospitals, in addition to the 2 state hospitals, for the provision of involuntary commitment services in the state. Under the statute, the non-state hospitals are not permitted to apply for an individual's commitment. The applications are always either on behalf of the state hospital superintendents or on behalf of the commissioner of DHHS. So for example, if St. Mary's Hospital has accepted an individual or admitted an individual on an emergency, what's called a blue paper, that person is admitted to the hospital on an emergency basis. Within 3 days, the chief administrative officer of St. Mary's would have to make a determination: do we need to continue holding this person involuntarily? And to do so, we need to ask the commissioner of DHHS to apply for the person's commitment. So at all of these hearings, and I can say our office handles, you know, upwards of 1,000 of these every year. They happen every single week. Some hospitals are happening every week. Others, you know, every other week or so. We are always there on behalf of either the state hospital superintendent or the commissioner of DHHS. And we're clear with these hospitals that we don't represent them. That said, at the hearings, the statute also requires, as part of the evidence, the presentation of expert psychiatric testimony. And that is to explain what treatment is happening at the hospital. It's to explain the mental illness element, all of that. And so at these hearings, the AAG, who is presenting on behalf of the DHHS commissioner, will be calling witnesses who are from the hospitals. Of course, the person who has the most critical information about the patient is the psychiatric provider who is currently treating the patient.
So if that's all done by contract, might we be able to expand the existing contracts to also include ACT teams and take advantage of the expertise in the AG's office? Obviously, understanding that there have to be expansion of resources and additional costs and things like that. Is that within the realm of possible? And I understand I'm only asking the AG's office, and Molly will have something to say shortly in my ear. But is that possible?
Senator, that's a good question. These are questions that were in similar questions that were raised either last session on a prior LD. I know Representative Perry and our legislative liaison from my office met to discuss some of those concerns. There were concerns from the AG's office regarding a similar bill, which would have required that the applicant, I believe that it required the applicant in all PTP cases to be the commissioner of DHHS, and removed the opportunity for a hospital superintendent or chief administrative officer to be the applicant. So it essentially took all PTP applications would have had to go through the commissioner's office. Mm-hmm. And it became concern to the AG's office because inevitably in creating these plans, these individualized treatment plans, and not inevitably, but oftentimes it involves giving legal advice. And, is this plan, if you're discharging a patient from the state hospitals, is this plan, going to mitigate some risk that could occur without sufficient services in support of the individual once discharged? So, and it also involves, the plans themselves are somewhat of a, akin to a contract. There's different parties, providers who are signing up to do X services. The patient is required to do X services. So the development of the individualized plan does or can contemplate this notion of providing legal advice. And that's where there was some concerns on that prior LD with the commissioner being responsible and therefore the AG's office providing legal advice on all of these plans.
The other expert I'm aware of is Honorable John Nutting when we get a chance.
Thank you, Senator. Senator Moore.
And I appreciate all of this conversation. And I guess I'm wondering because we also have LD 869 that is on our schedule for today. And this is the one that was the resolve directing the department to review this whole PTP program and process and take a look at it, review the efficiency and the effectiveness of the process. I'm wondering if we should maybe combine these two bills, because it sounds like there's a lot of moving parts to it. And I'm wondering if the stakeholders group could make sure and look at this and see what's going on with the process itself. Do we modify it? Do we include it? Do we make these changes? It's a thought. I mean, we've got that vehicle there to actually take a look at the whole process itself.
Thank you, Senator Moore. Senator Nutting. Welcome.
Thank you. Thank you very much to the committee for letting me speak. I just, we parents kind of heard a rumor a few days ago that the AG had some concerns. Initially, we didn't think that was true because they did not come forth at the public hearing. That, of course, was 10 days ago. We could have used it 10 days to help work on things. But I personally, and I've talked to numerous parents that have personally watched the AG give professional advice to non-state hospitals for commitment hearings. I've been in the room. Many other parents have watched the Attorney General's office give excellent and proper strategic advice to non-state hospitals for commitment hearings for years and years and years. A PTP hearing, though, really a PTP hearing is nothing more than a medical contract that's drawn up between the hospital and the community mental health providers. And it is a medical plan. And the Assistant Attorney General's office really doesn't give any advice there to a PTP hearing because they're not a medical professional. And so for NOAC teams to have been able to afford to bring forth a PTP hearing, as we remember from the public hearing, our concern is for like Chris Pickering in Bangor, who's did great on the PTP plan, had stopped his treatment plan after a while, was starting to decompensate some, was not bad enough to be committed. The ACT team there knew what was going on, couldn't afford to initiate a PTP. He's now deceased. We're trying to, with this bill, simplify the process like what's done in 45 other states, frankly, so that we can intercede in people's lives before bad things happen. And so that's all we're trying to do with this. So we parents, we're, thank goodness the AG for years has been giving advice to commitment hearing for non-state hospitals because they're expert at what they do. We just would like there to be a way through a contract, through reimbursing private attorneys, so that the ACT teams could financially be able to intercede in someone's lives before really, really bad things happen. And with that, I'll thank you for giving me the opportunity and be happy to answer any questions.
Questions? Yes, Senator Baldacci.
One, I want to welcome the Honorable John Nutting. It's very nice, and thank you for your advocacy, sir. And as we all know, Joe Pickering Sr., we heard from Joe Pickering Jr. just earlier, but Joe Pickering Sr., and I know his family is working hard on this issue because they want to prevent other families from having to deal with this again. Joe Sr. as well as Joe Jr. are great advocates but Joe Sr.'s worked hard on this. I think, and I heard the concerns of the Attorney General's office, and I think that if there's a way for this, first of all, I think that this is an important bill. This will help speed the process. I think if we can change, if there's a way we can ask for a general fund appropriation, or because ideally the court-appointed attorneys in general are paid through technically the judicial branch or the Commission on Indigent Services. So there are other avenues where this could be paid for, so it doesn't represent a conflict with the department's mission. So I think that we could look at other places where this could be spent from. It doesn't have to, if it doesn't have to come, if it can't come technically from the department's budget, there are other ways to make sure this happens. So I think we need to look at that. Typically, the judicial branch is where these type of things are funded through. So we may have to work with their offices and figure out a way, but I don't want that to be the thing that holds us up on this bill. Thank you.
Thank you, Senator. Yes, Mr. Nutting. You're muted, sir.
I'm also quite technologically challenged, but I'll
You
do
are
the
not
best I
alone.
can. It's just so frustrating for Maine parents going through this, to talk to parents in other states. And they say, well, you know, we have this process, and if somebody is stopped their treatment plan just 6 weeks, let's say, and they're really not bad enough to be committed, but we jump in quick through like Kendra's law in New York, and you know, different states call them different things, and we prop them up intensely before they get really bad. It's just frustrating for us in Maine to be an outlier state that somehow, so far anyway, and we're open to any type of solution. We have a concern if we do a study, we're really looking at 18 months closely before anything could change. And that's a long, long time for other people like Chris Pickering's situation to be out there. Again, thank you very much.
Senator Claxton.
Yeah, Madam Chair, I appreciate that we're way into the weeds. This has been a long consideration. I think the options at this point are to table it and see if we can't resolve the revenue source and add in the experience from other states, or to move to carry it over so that work can continue. The revenue source by itself is a issue we can't sort of sleight of hand not deal with in passing such a bill. I'm not familiar with what's happening in other states, but I'm certainly willing to work on it. And I hate to put it off because of what Senator Nutting said. But that's a big unresolved issue, and the legal issues that the AAG has raised are not inconsequential. I just put that out there for the committee's indulgence, and I appreciate the committee's attention.
Thank you, Senator. I wonder as well, going back to Senator Moore's comments about Representative Perry's 869, which is upcoming. If the issue about regarding contracts and contract language and just the broader issues that we are somewhat in the weeds over here could be addressed in Representative Perry's bill. So just something for the committee, I think, to further consider. Yes, Senator Baldacci.
Yes, I would prefer that we try to handle it and not have to carry it over. So I would make a motion right now just to table it. And I'm happy, as an attorney who's worked in this process, not with the PTPs, but with the involuntary commitment issues. I'm happy to help out if I can, but I think that we need to look at the judicial branch or something like that for the funding source. But I would move to table until we can work those issues out.
Okay, do we have a second for the tabling motion?
Second.
And a raise of hands for those. Okay. Thank you very much. With that, I think we have been here for more than an hour and a half, and perhaps a 15-minute break at this point, returning at noon. Senator Claxton, you in agreement with that?
I'm fine with that. Yeah.
So a 15-minute break, and we'll see you all at noon. Senator Claxton,
Yes.
I'll be handing the gavel over to you, and I need to step away for about 5 minutes.
The virtual gavel.
But
Very good.
carry on.
I will. Thank you, Chair. Okay, so at this point, we can resume our morning session now that we're in the afternoon. With consideration of LD 869, you heard it referenced earlier. It's a bill from Representative Perry. And we'll see what Aaron has to say about it.
I'm sure you can't wait to hear what I have to say.
On the
about
edge
it.
of my chair.
LD 869 is a resolve directing DHHS to review the PTP process and the process by which a person may be involuntarily admitted to a psychiatric hospital or received court-ordered community treatment. The resolve is emergency legislation, and it directs the commissioner of the department to convene a stakeholder group of interested parties to review the progressive treatment program under Title 34B, Section 3873-A, to increase participation of non-state mental health institutions in that program. Review for efficiency and effectiveness, processes by which a person may be involuntarily admitted to a psychiatric hospital or receive court-ordered community treatment pursuant to another chapter under Title 34B. The resolve directs that membership in the stakeholder group should include the Office of the Attorney General, Riverview Psychiatric Center, Northern Light Acadia Hospital, Spring Harbor Hospital, Maine Hospital Association, the Alliance for Addiction and Mental Health, and an individual who has been a patient or a family member of that person, and to invite the participation of the judicial branch. The commissioner is directed to submit a report with recommendations to this committee by December 1 of this year, and the committee may report out legislation to next session relating to those recommendations. You received some suggested amendments from testimony related to the membership of the stakeholder group and expanding that group to include an individual who has been a patient and a family member of the person, an advocate for patients' rights, such as Disability Rights Maine, advocates for family concerns, Consumer Counsel System of Maine, and PNMI providers, ACT teams, and other community providers who administer PTPs, including psychiatrists and psychiatric nurse practitioners. I did just want to note that in relation to the PTP section of the resolve as drafted, it's narrowly focused on increasing the participation of non-state mental health institutions in that program, which is why I think it was heavily drafted last session to include Acadia Hospital in Spring Harbor and the Hospital Association, because it had that narrow focus. Increasing the membership might trigger a discussion about increasing the scope of the review under the resolve. But as drafted, it's not a review of the entire PTP process in that first section.
Any comments from the committee having heard that analysis? Representative Perry.
Yes, actually, in looking at that, I would like to suggest we do broaden that to look at the whole PTP process. And especially after the discussion of the last bill, where ACT teams also struggle with what to move forward to have that representation, include that level of treatment as they do, they are the ones that provide the PTP program. Yeah, and so I guess I haven't, sorry, Aaron, I haven't been in touch with you on that, but I would like to broaden that to include the other recommended participants and also broaden the scope for the whole program.
Would you consider it a friendly amendment to include the language that already exists under the PTP statute? which references chief administrative officers of a psychiatric hospital, the commissioner, director of ACT team, medical practitioner, law enforcement officer, or legal guardian. So we could broaden to make sure that there are representation from all of those folks. Any other comments? Thank you, Representative Perry. I'm not seeing any questions or concerns. How would folks like to proceed? Senator Moore.
I'll go ahead and make the motion then that we do an ought to pass as amended with the reference amendments to LD 869.
I second
Did I hear a second?
I second that.
Okay, so the ought to pass as amended, the amendment being the expansion of the scope and participation categories, both.
Senator Claxton, you
I
froze.
think Senator Claxton.
I was wondering who it was.
Looks
I
like
think that-
maybe,
Yeah.
looks like maybe he's trying to correct a connectivity issue.
So our next step will be to proceed with the vote, probably.
I think the next two words were Miss Withy.
I'm sorry, I just came in. Can you tell me what we're poised to embark on vote-wise?
We're looking at LD 869 and going ahead and doing an amendment. In section 1, we're going to expand the scope to take it to even more, to actually look at the entire process itself instead
Okay,
of just
including the process we just discussed in the previous LD?
Yes, because it would be all of them. And then also to expand the membership of the stakeholders group. And the sponsor was quite receptive to that.
Thank you, Senator Moore and
You're welcome.
Representative Perry. So let me see if I can find Senator Claxton. Bear with me.
While I'm waiting, Carrie, did I miss a vote earlier while I was testifying elsewhere?
Yes, Representative Zager, it was LD 38.
And was the motion was what?
Ought to pass as amended.
And that is my vote as well.
Thank you.
Thank you.
Sorry for that brief incident. I was doing what I could to meet the quota of technical problems for the day. And my Wi-Fi, my wireless system quit. So I think we were looking to turn to Miss Withy to collect the vote on LD 869, the motion on the floor being ought to pass as amended.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin? Yes. Representative Connor? Representative Connor is absent. Representative Craven?
Yes.
Representative Craven? Yes. Representative Madigan?
Yes.
Representative Madigan? Yes. Representative Javner? Representative Javner is absent. Senator Moore?
Yes.
Senator Moore? Yes. Representative Meyer?
Yes.
Representative Meyer? Yes. Senator Claxton?
Yes.
Senator Claxton? Yes. That's 11 yes, 2 absent.
Thank you for that. Now we'll move to consideration of LD 1603, brought by Representative Meyer.
Senator,
Yes.
before our analyst begins her analysis, I just wanted to offer to the committee an amendment to 1603. That being that we would strike section 1, leaving the bill simply to reestablish the committee to address the feasibility of basic income support. It's come to my attention that there is a great deal of work being done around the matter of improving the effectiveness and accessibility of Maine safety net and work support programs. So I would like for the various departments involved to continue that work, and perhaps it is an issue that we revisit again in the short session. But I offer that amendment to the committee prior to Aaron's analysis.
Thank you for that. Do you want to go ahead and do your analysis and review of that amendment, or independent of that amendment?
In view of that amendment, I won't spend time on part 1 of the bill. The second piece reestablishes the committee to study the feasibility of creating basic economic security to continue the work of the previous study committee. It's drafted similarly to the legislation authorizing that study last session, and there's a link to that resolve there. The bill directs the study to examine and make recommendations about the feasibility and economic impact and poverty reduction effect of providing basic income security through a direct cash payment system and other programs designed to help individuals and families become more economically secure. It authorizes the committee to seek funding contributions to fully fund the costs of the study, including the hiring of an outside consultant to conduct a feasibility study, or to provide the committee with additional staffing needs if funding permits. There was a question about for the report related to what that committee produced last session, and that report is hyperlinked there. The fiscal impact on the bill hasn't yet been determined.
I do want to point out, when you look at the language of the bill, though, under section 2, on the third line set 35, it talks about establishing the committee, and it sounds like a new committee, but in the summary, it uses the phrase reestablish.
Reestablishing.
Yeah, so.
Well, the summary is not law.
Is that an issue or not? Is that an issue or not? Okay, as long as it's not an issue, we will.
The committee ceased to exist, so it needs to be established.
Okay.
But for context in the summary, the term, I think, reestablishing would be used to show that this is the same work or continuing that work, but the committee doesn't exist, so it has to be established.
I'm just wanting to be careful. Representative Meyer.
Thank you, Mr. Chair. I think also this could be a resolve.
It would have to be, yes.
Yeah. Okay. And you mentioned reference to a letter. I
did. I thought if the committee is in agreement that we might send a letter to the department recognizing the work that's being done, encouraging additional work towards modernizing the system. Also using some of the ARPA funding that's being utilized to or planned to be used to modernize state government. That within the context of that, where we also are taking a look at modernization of our safety net and work support programs.
Thank you. Senator Moore.
Yes, I would go ahead and make that motion of ought to pass as amended, as referenced by Representative Myers on LD 1603.
I'll second that.
And there's a second. Thank you for that. Is there any additional discussion before we vote? Not seeing any. We'll turn to Ms. Withey again.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Thank you. So once we got my two bills out of the way, we're moving right along. That doesn't seem fair, but all right. Next, we'll go to LD 1487 for consideration. That bill is currently on the table, so I would need a motion to remove it from the table.
So moved.
So moved.
Moved and seconded. I think we can do a show of hands to take the bill off the table for consideration. That's unanimous of those present. Thank you all. So now we can come back to consideration of 1487, which was brought to us by Representative Stover. Any comments?
So I think you had requested input from the DOC, which you received this morning. I know Gordon Smith should be available to answer questions, as are Jessica Pollard from the department. And Molly had sent some data regarding county jails and MAT to your emails, and I'm sure they could speak more to that.
Very good. So Representative Stover?
Excuse me. When you think you're muted and you're not. Thank you, Senator. So this bill is an attempt to provide a mechanism to reduce untimely deaths, overdose deaths when people are leaving incarceration. As we heard this morning, there's an initiative at the state prison level to provide injectables, which is what this bill really is aiming to do, is to provide injectable medication to someone prior to leaving. And if that provision is there now in the state prison, I wasn't aware, that's wonderful. However, there's still that gap, and all of those people who are served across the entire state by our county jail facilities, injectables, as to my knowledge, are not in the formularies to be provided. So this bill was an attempt to add that as part of the options under medication assisted treatment, much like they're doing at the state prison level now, which is really great. So that is, we've talked about this extensively. I think we've all acknowledged in our areas of the state, we've all seen people who have left the county jail system and sometimes the state prison system, and we've lost them. So it's just, it is an attempt to address that gap, especially when someone first walks out the door, which is the highest risk time for them. And I see that Gordon Smith is here, and maybe he would like to speak to this as well.
Again, well, I think we had this conversation the first time, but as I read the bill, unless there's an amendment that I'm not reading about, it doesn't specifically reference long acting. Are you comfortable with the full range of MAT options as the
Yes.
language?
What we discussed at the hearing was, instead of limiting to Sublocade, instead having long-acting injectables as the language, because some people may choose, for instance, Vivitrol, and there are others.
Right. So you're really looking to expand the the offerings or the availability. Okay.
The option within the.
Because long acting and a specific name aren't in the bill that I'm looking at. So that's why I'm confused.
Well, and perhaps we could amend that
But
to include those.
so is it comprehensive enough to refer to the full range of medication options appropriate for MAT?
Would it be including but not limited to?
Okay. All right. Representative Perry, before we go to Gordon Smith.
Yeah, I had a question. I think you actually took care of it. Is if we're talking about main care, we can't limit medications and on that piece of it. And I was very impressed with what they are doing now in county jails and the prisons. And they did mention using Vivitrol in the county jail upon discharge. We also have really to do a waiver to the federal government that already has a rule that says your insurance, Medicaid and Medicare does not follow you into jail. So I'm wondering how far this bill can really go.
That's an excellent question. And, you know, as you heard from the state prison, they're ensuring that all of the people who are being released from state prison have it the day they walk out the door. And I'm not sure that same provision consistently exists in the jail system. However, I'm not sure that what we're doing right now adequately addresses the rate of untimely death, overdose deaths, and whether or not figuring out the way in which injectables could be used in that last month of stay, even though sometimes county jail stay is a little unpredictable. If there's a way to at least offer that as another treatment option or medication option. Treatment is the other piece of this.
Representative Stover, was it your intent to have this go forward independent of the waiver or dependent on the waiver?
I had originally put in the waiver because currently, as we had discussed, there's a waiver application process going through in Kentucky. However, I don't know how long it's going to take to see where that Kentucky waiver application goes and whether or not it has any viability. If it does in fact have viability, it would be great to go back and look at that and see how Kentucky did it. But that information isn't available right now. And I would be interested in hearing from the department, from Dr. Pollard, whether or not she thinks that waiver is an option, because otherwise we're really talking about a fiscal note. And as we heard earlier, there's a significant commitment from the Department of Corrections and the Office of Behavioral Health towards MAT at this time, and this could be added, perhaps added in the options. So the short answer is not necessarily if we consider another funding mechanism, if the waiver is not likely to work.
So you're looking for a waiver or an alternative funding mechanism? Okay.
Yes.
Is that something you can speak to, Mr. Smith? Welcome.
Well, thank you. Gordon Smith, the State Director of Opioid Response. I am here accompanied by my partner, Jessica Pollard, and she can add to what I'm going to tell you very briefly. Molly's, of course, with us as well. I want to apologize first for not being at your first work session on this bill. I did review the tape, and I really wish that we'd been able to present you with that information. We were simply not available to help Molly that day. We have acquired the information since. You have it, some of it in front of you, how many people the jails are serving, There is a program in every jail, and I think it's very important you understand how these are funded. Dr. Pollard will give you some further detail on it, but the Office of Behavioral Health is putting in approximately $1 million a year into these projects. You'll remember that, you may remember that Executive Order 2 signed on February 4th, 2019, the first day that I started. This was one of the 4 initiatives that the governor and I talked about, making certain that every person incarcerated in the state of Maine, whether in a county jail or in the Department of Corrections, had access to treatment, medication-assisted treatment. So we're very proud of what's been accomplished. You heard, I thought the sheriff presented that information well. Certainly Dr. Thornell, particularly when you consider the pandemic and that we weren't able to get recovery coaches in the jail, because recovery coaches are a part of this work as well. For that year, I think the Department of Corrections has done an extraordinary job with their program, and the jails are trying. Now, again, there's still 3 maybe that we don't have a contract with, and that's mostly due to COVID-related issues. They've all approached the department, and so we're working with all the jails. I want to remind you that some of this is promoted by the federal court case out of Aroostook County, Smith 2, we call it, no relation to this Smith. But that established the principle in the First Circuit. It was affirmed in the First Circuit Court of Appeals that the inmate resident going in for a 90-day sentence in the county jail was entitled to continue her medication-assisted treatment. So again, it's just another variable that I wanted to remind you of. I'm going to very quickly now turn it over to Dr. Pollard, but it is very important to understand that our contracts are not with the jails; they are with the MAT provider in the jail, and then an equal amount to community providers to pick up that prescribing when the patient is released, when the inmate is released from the jail. We also track every week whether any of the fatal overdoses have had any connection, particularly whether they've been released within 2 weeks from incarceration. In 2019, there were 12, which was about 3% of our fatalities had been released. That's one is too many, but again, I don't want you to think that this is the predominant way that people are dying. I'm hoping by the time we finish this work session, they're getting me the number for 2020. I do not think it will exceed 12. I think it's probably come down a little, partly because of the tremendous work too of the Maine Prisoner Reentry Network. That's a volunteer organization that Bruce Nodden operates and that we give some financial support to now. But understand that our contracts pay for 4 forms of buprenorphine, but not Sublocade. And the reason is all about the financial implications of that. Short of a 30-day shot of Sublocade is about $1,500 to $1,700 a shot. And that's why we offer Vivitrol, Subutex, Suboxone. Sometimes methadone's a possibility. Obviously, the logistics of that are difficult. So while in theory, we would love to say it really ought to be between the inmate and the prescriber, which form of treatment is appropriate for them. It's been strictly a financial issue because we are using federal grants largely, but it really would break the bank if suddenly a lot of people were suddenly moved to that. And I think now that you understand that anybody that's been diagnosed with a substance use disorder that's in the jail system has access to Suboxone, both in the jail and then outside the jail, and that's paid for by main care. As Ryan said, 95% of those folks are eligible the day that they're released. And so that our costs go down, because then main care would be picking up the cost of that script. So again, this is not perfect. We've still got a ways to go in terms, some of the programs are quite small, but some of the programs are quite robust, and everybody is on board. And so the administration really has no position on the bill, because if you think that we ought to add Sublocade to that regimen, then over time the contracts could be changed to do that. But it would have very, very significant financial implications. Dr. Pollard will correct what I've said, which parts of my comments are completely erroneous. Dr. Pollard is going to correct you.
I don't think you said anything entirely incorrect. Just a point of clarification, I think you got the briefing that Molly forwarded along about the contracts. So the contracts are with the county directly or an outside substance use treatment provider, not with the medical jail provider. That's the only thing I would clarify about what you said, Gordon. And I think there was a question asked earlier about a waiver of coverage while incarcerated. And just, I double checked this again yesterday in anticipation of this conversation. We have seen continued guidance from CMS that they are not going to cover individuals while incarcerated. The Kentucky waiver has not been approved. We don't anticipate it will be improved. The only slight variation, if you want to call it that, on what has been allowable for coverage under Medicaid while somebody is in an incarceration-like setting is when a facility is designated as a halfway house, which is not really fully incarcerated. It's a secure setting, but the person isn't kind of locked in all the time. It's like kind of halfway house transition out into the community. But and I do want to make one more point of distinction, which is that there's a difference between the Medicaid coverage being billable versus it being active. It's not necessarily the case that Medicaid can't be left on, so to speak, while somebody's incarcerated if they already have it. It's just that claims can't be billed against it. Medicaid won't pay. And so our contracted providers do assist people who don't have main care, who are in the county jails, in applying for main care. But people who already have it don't necessarily lose it just because they're incarcerated. It's just that it can't be billed.
Okay. So one of the things we noticed on the presentation was the waiting lists for MAT as of end of April 21. What can we do with this potentially, or with additional dollars to help that number?
I mean, as far as once somebody has re-entered, the length of time between their last appointment while incarcerated and the first appointment in the community, is that the question?
No, I'm talking about the people, according to this April 21 report from the DOC, that says there's 200 plus people on a waiting list to get onto MAT.
Within the correctional setting?
Yes. What can we do to help with that?
Well, I don't want to speak for Deputy Commissioner Thornell. I know we have expanded the program within DOC, but I'm not in the best position to answer the question about DOC's MAT program.
Okay. Gordon, did you have something to add?
Well, I was surprised to hear about the waiting list. I think that's just a waiting list of just people within the custody of the Department of Corrections, not the jails. And again, they have a plan to have everybody on by July. It was originally going to be the end of. It's quite remarkable because they started out with so many days from your release day, and now even if an inmate is there for life, they're going to have an opportunity for the first time to be treated with MAT. And they're all the facilities are going to have that availability by midsummer. So I believe that we anticipate that wait list to be gone when within 2 or 3 months.
And are there additional monies coming as part of the change package for this effort generally?
I'll start by saying that most of what's coming through the Office of Behavioral Health, we've been using mostly federal grant dollars, either from STIMSOR, MSOR, block grants. And so we would be looking for those additional federal sources. We have a tiny bit of money in the general fund in the budget. We have that huge amount of money associated with paying better residential and treatment rates for main care, which is truly transformational in the behavioral health and SUD field. But I don't know that there's any money in the so-called change package that would be specifically targeted to this area. We would continue to look at our federal grants. Am I correct, Dr. Pollard?
I want to make sure I understood sorry, that's terrible feedback on my end. I want to make sure I understood the question. Is the question about funding for SUD services in the department's component, Department of Health and Human Services component of the supplemental budget, or are you asking about DOCs?
No, I was asking about the departments. Are there additional dollars to come that we anticipate? Yeah, that was the question.
And not to get super picky, I just want to make sure I understand answer your question correctly. Precision of language. Are you asking about specifically for incarcerated individuals, or just kind of broadly about SUD treatment funding?
Broadly, because a good percentage of them don't stay incarcerated. And yes, yeah.
Well, I went through all of that just to say the answer is yes. There is a longer question than it was an answer. Yes, we have a number of initiatives to support SUD treatment in the change package that we're really excited to talk about.
Good. Comments, questions for Gordon Smith or Dr. Pollard? Any responses based on this? Yes, Senator Moore.
Yes, I'm very pleased with how far we've come with our progress on our MAT, not only in the prisons, but even in our communities. And my hat goes off to Gordon and also to Dr. Monahan as well, or Paul, excuse me. In view of that, I really do not think we need this bill. I think that the work is being done. So I'm going to make the motion of ought not to pass.
I'll second that.
So there's been a motion and a second. We now have some time for additional discussion. Representative Stover.
So I just wanted to thank both Gordon and Dr. Pollard for being here today. And one thing that this bill did was allow a very robust conversation about the options that are available now under medication assisted treatment. And I'm fortunate, I work in addiction work in Lincoln County, and we have a couple of ex-waiver providers who are getting prior authorizations and are using Sublocade. I have a couple of clients who are using it whose lives have been transformed because they don't have some of the side effects, which I won't get into, are kind of unpleasant, and that's been taken away. So I know that it works for some people, and I hope as this treatment, as we continue to explore and implement that, maybe the price will come down and maybe it'll become more available, but I still think the concept is a really great one, and it provides an opportunity to people now on the community side. With some providers, and I see how it works. So I appreciate everybody's time and effort on this. I think it has opened up a dialogue that I think was critical for us to all be knowledgeable of and continue to talk about.
And if I may,
please.
I think we want to keep an eye on the literature there. So far I haven't seen any comparisons that I think it's just too early to tell whether there is an appreciable difference. I know so far among the existing studies, there's not much of a difference in terms of functional outcomes between the different types of MAT and delivery methods. But we will absolutely watch how that goes to see if over time there does seem to be a good reason, a good literature to support the trying to fund something despite the expense.
As we've learned over the last year, our understanding of things continues to change, constantly evolving. Representative Stover, is your hand still up, or did you want to make another point? Okay, so it's just my imagination. Okay. So there's a motion on the floor, ought not to pass. It's been moved and seconded. Are there additional comments or questions? Seeing none, we'll turn to Ms. Withy to record the vote.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan. Yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 11 yes, 2 absent.
Thank you very much for that. And thank you, Gordon and Dr. Pollard, for making yourselves available to help us with understanding these things. So keep up the excellent work.
Thanks for having me. And unless you want to kick me out, I'm happy to stay around for the next work session as well.
All right, just so long as you know that I control the mic. All right. All right. Now we can go to 1653. Representative Meyer, this is you're officially the sponsor. This is the EMS.
Yes, thank you, Mr. Chair. And I would ask Ms. Bogart, and also I think we've got some folks from EMS.
Who's here?
I'm not sure that we have folks from EMS.
Okay, so, but we have Molly Bogart.
You don't need anybody from EMS. So since this is, do you have anything you want to contribute to this conversation at this point, Aaron? It's rulemaking.
Just going to summarize an overview of what the rule did, but
That'd be great.
it's not super illuminating. So I don't know, you might just want to move on to Molly.
Okay. All right. Not
I
super.
mean, I can if you'd like me to. I don't mean to be flip, but
No, that's okay.
I don't know if it'll add much.
We'll go to Molly. Anything that you think we should know before we can proceed too much further in consideration of LD 1653?
I don't think so. But
The presentation was pretty cut and dried. We had a chance to ask your questions. Yes, Senator Moore.
Yes, I agree. It seemed to be very cut and dry and straightforward. So I would make the motion of ought to pass.
And I'll second that.
Very good. Motion's been made and seconded. Is there additional discussion? Not seeing any. We'll ask Ms. Withy to record this vote.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin? Yes. Representative Connor? Representative Connor is absent. Representative Craven?
Yes.
Representative Craven? Yes. Representative Madigan?
Yes.
Representative Madigan? Yes. Representative Javner? Representative Javner is absent. Senator Moore?
Yes.
Senator Moore? Yes. Representative Meyer?
Yes.
Representative Meyer? Yes. Senator Claxton?
Yes.
Senator Claxton? Yes. That's 10 yes, 3 absent.
Okay. Now we can go to Senator Breen, who has joined us. And we'll be considering 3 bills that she's attached to or attached to her. 196, 197, and 674. So let's start with 196. Senator Breen, welcome.
Thank you, Mr. Chair, and hello to everybody on HHS. I know you've had a big full day. Thank you for all your good work. This one is the rate one or the federal funding one?
This is the rate one.
Okay. I would urge you to put this in the context of other rate bills and make your best judgment based on what you've heard. Excuse me, I know that you folks have done a lot of work on an omnibus rate bill. So I would defer to your judgment on that.
Can you speak to the underlying assumptions that got you to the fiscal note in terms of the percentage change in rates?
I don't have it in front of me. I apologize.
No, that's okay. That's okay. I was trying to figure out whether it was in line with the 25% we've been talking about.
It's 25% from where it is today.
Yes. Okay.
Yes.
That's what we were talking. That's what we've done so far, or in one case, as of where it was in 2019. But yes, Representative Craven.
Thank you, Mr. Chair. Should we take it off the table? Since we're talking about.
We should probably do that. Okay.
I move that we remove we remove it from the table.
Moved, and is there a second?
Second.
Okay, we'll do this with a show of hands to take it off the table. Thank you, Representative Craven. It even has on the table under my notes, so appreciate that. Aaron.
I just want to clarify that this bill as drafted proposes a 15% rate increase. The bills that you had been considering, I think last week, being swept into 1573, I think are a 25% rate increase.
Yes. Well, we can fix
20.
that.
Yeah.
Yeah. So, and you can help me too, Aaron, in terms of the groups that are covered by the work we've done so far. This is not specific beyond section 65, right? This bill.
This bill is about 65 and 17.
17, that's right. But
and LD 283 included a 20% increase under those sections as well.
20 or 25?
20.
Okay.
Then
Fair
you
to
voted.
giving me a raise. That's great.
Would that it was that easy. So these have already been dealt with, 17 and 65 have already been dealt with in a prior bill at a higher rate.
I believe that's my understanding of those bills. Yeah.
So we voted on it, so it's going to land on the table if it hasn't already. So that becomes in your bailiwick. Senator Moore?
I was just going to say, since they are already included in our previous bill, then I would make the motion of ought not to pass on LD 196, since we don't need that vehicle.
Is there a second?
Second.
Okay, so the motion's been made and seconded that LD 196 ought not to pass because that work's been accomplished at a pay raise or increase higher rate. Any discussions? Aaron, is your hand still up or did you have another point? Okay. Any further discussion? Then, yes, Anna, welcome. We're not hearing you, Anna.
Sorry, I'm sorry to jump on this, but this was not the 25% in the other bills. This was swept into 1573, as Erin mentioned. This is the one that is 125% of the minimum wage. This is part of Representative Madigan's bill, 283. Hers was originally 20%. This one was 15. You swept Representative Madigan's bill into 1573 with 125% minimum wage. This is not the 25% bills that you did the other day that were related to the higher level clinicians. This is the direct care folks, which Representative Madigan knows much more about than I do.
All right, sorry for confusing everybody.
There's been a lot of rate bills here and it's okay.
There have been a lot of rate bills, like about 15. So doesn't really change the fact that this group has already been approached in work we've done already, and arguably at a higher rate than we were at before. Any other comments? Thank you for that clarification, Anna. Any other? So Ms. Withy, why don't you record the vote? The motion on the floor is ought not to pass.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lumlin.
Yes.
Representative Lumlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan. Yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 10 yes, 3 absent.
So that allows us to move to 197, which is the federal dollars, 15 million ask of available funds or future funds, whichever. Any thought, any reflection on that bill at this point, Senator Breen?
Thank you, Mr. Chair. I put this in very early in the year because over the summer when appropriations was meeting multiple times, thinking we were going to have a special session last fall, we heard from a lot of different entities about the effects of COVID-19 on the services that they're able to provide in the community. There were a lot of providers who received federal money, often directly from the feds. For instance, hospitals and nursing homes and assisted living. But there were a whole other group of providers who were not in line for federal money and had to do spend a lot and change over, spend a lot on their own on PPE. Can change over entirely to telehealth without any additional funding to help do that. And their census populations went way down because of the pandemic. And so my thought on this is that we have federal money now coming to us. And again, there is federal money going directly to hospitals and nursing homes. But there's still a bunch of community-based mental health providers who are really, really struggling to keep their programs intact, pay the rent, manage their overhead costs, and keep their folks employed. They were not eligible for PPPs loans because of various status, either nonprofit status or their size or what have you. And so to me, a bipartisan vote to give some federal money to these folks would I think go a long way. So that's my request. I'll leave it at that.
Thank you. Related to that, we should probably take this one off the table too before we vote. So I'll entertain a motion to take this off the table.
So moved.
Senator Moore made and seconded. That's why she's laughing at me. Okay, all those in favor of removing this then from the table so we can formally consider it. Thank you all for that. Glad to provide some humor in your day, Senator Moore. Any other thoughts or questions about what we've just heard from Senator Breen related to LD 197? I'm not seeing any. This too would end up on the appropriations table and would be dealt with along with other priorities. So at this point, no questions and no further discussion. I entertain a motion.
So moved.
Ought to pass. Is that ought to pass is the motion? Okay.
Yes.
Is there a second?
It's amended by the fiscal note.
Yeah.
Second.
Ought to pass as amended, the amendment being the fiscal note. Any further discussion? I'm not seeing any. So, Ms. Withy, why don't you go ahead and collect the vote on this one?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lumlin,
Yes.
Representative Lumlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci, Senator Baldacci is absent. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner, Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you. That allows us to move to consideration of LD 674, also from Senator Breen. And we need a motion to take it off the table.
So moved.
Second.
All those in favor of proceeding with the discussion of LD 674? I understand that you have an amendment for us, Senator Breen. Is that true?
It is, and I want to thank your analyst, Aaron Dooling, for helping me in drafting it. After our initial public hearing on this bill, I did some outreach and work with the department, with the folks at Maine Med and the peer program who have the program running now and are hoping to grow it to other locations. I think what I heard from the department is that we're in sort of a chicken and egg situation about filing for federal approval to develop a bundled rate for this group of services for this program. If they get the federal approval without the general fund appropriation, there's some hesitancy about whether they would have to go ahead and offer that. and without the general fund appropriation. So there was some hesitancy about that, which I understand. So with Aaron's help and the help of the folks in OFPR, you have an amendment now that basically says once the general fund appropriation is in place, the department will then go ahead and file their paperwork with the federal government for approval of this new bundled rate. And that then once the approval is available, then the program, then things will be ready to go. And it also says if the general fund appropriation doesn't happen, then there's no expectation that all of this, or sorry, if the federal approval doesn't happen, there's no expectation that all of this would be paid out of the general fund. So it's my best attempt, and again, with Aaron's help, with input from Dr. Pollard, to move this forward in a way that gives everybody what they want, and it's done in a way that won't wind up with any unintended consequences.
Can you put that up for us, Aaron? Do you have that amendment available?
Yeah, that's what I was going to ask. I'm sorry, Senator Brain, I didn't know
That's
I could
okay.
share it, so the committee hasn't seen it.
And Aaron, these are, I think, fairly routine amendments that you might be able to explain better than I just did.
So this is a contingent effective date. It means that, so basically the provision of this act that that would establish the peer program would take effect only if the necessary approvals are received. So that would mean that if the department receives the waiver or estate plan amendment from the federal government, then the program will go forward, and that it directs the commissioner to notify the Secretary of State, Secretary of Senate, the clerk, and the revisor when those approvals have been received. So basically, it makes the entire program contingent, going into effect contingent on receiving that waiver. And I just want to make sure that is the intent. It doesn't say that the department would implement the program using exclusively federal funds or other funds. So I just want to make sure that, I guess as drafted right now, it would mean that the peer program doesn't take effect unless a waiver's granted, period. So just wanted to make sure I'm on the same page with the sponsor about
Yes.
that. Okay.
Yes, and it will, I believe, go from this committee and we'll get a fiscal note, and then it will come to the table for the general fund portion.
Okay. And you in your comments reference general funds, but this takes it out of that realm. Do I understand that properly?
No, you'd be, by receiving a waiver, you'd receive federal matching funds
Matching
to
funds,
a
okay,
general fund
Okay.
appropriations.
Okay.
So it would
Thank
be a newly eligible service under main care.
Yes. Okay. All right. Any questions about that? I see that Dr. Pollard was here. There you are. Can't find you on my Hollywood Square screen. Any other comments, Dr. Pollard, related to this bill?
No, I think the amendment makes a lot of sense so that we can maximize federal, or that we can realize federal match for the program. And we are very happy to implement the coordinated specialty care model.
Very good. Representative Meyer,
Thank you, Mr. Chair. I'd like to make a motion.
please.
LD 674 ought to pass as amended.
And in this case, the amendments of the fiscal note and the change in language that was just submitted.
Correct.
And I heard a second. Thank you. So it's been moved and seconded. Is there additional discussion? Yes, Senator Breen.
Thank you, Mr. Chair. I just wanted to let you folks know also that I'm very interested in getting private insurance to cover this. My understanding was that that was already happening, but that understanding was corrected recently. That I think is going to be a different bill in front of a different committee. And I'm looking forward to working on that in the interim and getting private insurance to cover this program. But in the instance of efficiency, I didn't want to add that to this bill at this point, because then we'd have to veer off over to HCIFS and it would just get too complicated. So I just want to give you an update about my intention is to go beyond main care with this program and work with the private insurers to do that as well.
Thank you. Dr. Pollard?
I remember to raise my hand this time. I just was looking at the version that was available online, and I just want to make sure, because I didn't see in the amendment about the date of the deadline to complete the waiver application is June of this year. I wasn't sure if that was still in the deadline in the current version. We appreciate the contingent upon the waiver language, and still, given the number of rate bills that would potentially pass and the work of the department necessary to implement that, I just need to be mindful about bandwidth to complete a waiver application.
Do you have a proposal for how far out that should move?
Well, I'm not sure we could get it done within the next 2 months. I don't mean to be cagey. It's really kind of dependent on how much additional work is levied with the passage of the number of LDs that are in consideration that require other waivers as well. So, I'd like to see us get at least, 6 months so that we can make sure that we complete it on time, although I don't think it necessarily will take that long, but the calculus is very challenging given the number of other waivers that are potentially facing main care with this session.
Senator Breen, would you accept 1215 or 11 as a reasonable amendment?
Yes.
Does that work for you, Dr. Pollard?
Yes, that should be more than sufficient time. Thank you.
Okay. I think
which date is it?
1122 for getting the waiver completed. It currently references 6/30/21 on line 13.
Okay, and then on line 20, that's about establishing a bundled rate upon approval of the waiver, which is currently 6 months past the date of the filing of the waiver or state plan amendment. Are you looking to push that out 6 months after 1/1/2022?
Sorry, I was referencing line 13 in the version that is on the legislature's page about by June 30, 2021. That's for the submission of the waiver, not the approval of the waiver.
I know, I got that, but if you look further down on line 20, it says upon approval of the waiver and no later than January 1, 2022, the department must establish a bundled rate. And so because that date is the same as the date you'd be submitting it, I don't think.
I'm sorry, I thought the amendment that you just put up removed that part and made it contingent upon approval of the waiver. So I didn't think that date was in there anymore as of the amendment, but I may have misunderstood your amendment.
I think the effective date of the amendment the contingent effective date applies to the program as a whole, the reimbursement process starting. You still are directed to actually develop what that rate would be upon approval of the waiver, is my read of.
Oh, that's, I guess, confusing, because we would have the rate developed upon application for the waiver. Like the rate would already be developed with the application.
As part of the application process.
Yeah, I mean, in fact, we really already have the rate developed. We just need to apply for the waiver.
Okay, so that language about cooperating with DOE and DOL to create that bundled reimbursement rate, all that work would happen prior to the waiver being submitted on 1/1/2022.
yeah, we can certainly double check with them about the work we've already done to make sure that if that feels necessary to Senator Breen.
So it doesn't sound like that date needs to change since the work is already done or largely done or being double checked.
No, but the language about upon approval would need to change then because it would be done before, not upon approval.
Can we just strike the upon approval down?
Yeah, I can just change it to upon submission too, or upon
Yes.
submission of the plan or something like that. That's consistent with what folks want.
I like upon submission personally.
And then the amendment makes it clear that the enactment of the rate does not occur without approval of the waiver. Okay, that
Yes.
sounds like it's all lining up.
Yep. Okay, so we've added one piece to the amendment is to change a date. And another piece is to change the language that to upon submission. Everybody comfortable with what we're voting on now? Okay, so the motion on the floor is ought to pass as multiply amended. Okay. Carrie.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lumlin.
Yes.
Representative Lumlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan. Yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 10 yes, 3 absent.
Thank you, Dr. Pollard, for being here. And I understand you're headed to another meeting. And thank you, Senator Breen, for finding time on the AFA table, off the AFA table to come talk to us. All right. I would ask the committee's indulgence to hear one more bill before we have a reasonable lunch break. It's too late. It's later than we want, but at a request of one of our colleagues, Representative Babbage, he would like to be done. He has to be done by 2. He has an important meeting at that point. So can people hang in there? If you're feeling lightheaded from lack of nutrition, please feel free to step away and get your lunch. But I do want to hear Representative Babbage's bill LD 1657. And so we can reach out to him and see if he's available. Otherwise, we can start by hearing from Anna about that particular bill and get the process moving. Thank you for that indulgence, but please feel free to step away as we normally would in the committee room. People will be getting up and going off to take lunch in stages. So.
All right, LD 1657, a typo right at the beginning, how about that? An act to protect the health, safety and comfort of elderly residents and residents with disabilities by ensuring backup access to electrical power in certain facilities during power outages. So this bill has a couple of pieces to it. The bill requires that a facility that hosts an assisted housing program and is built after October 1st, 2021, has a source of continuous emergency electric power, such as an emergency generator. It requires the property management company or owner of a facility that hosts an assisted living program to implement an emergency management plan that requires an in-person well-being check be conducted for each resident within 2 hours of an unplanned continued loss of electric power. Secondly, it requires the property management company or owner of a senior housing facility of more than 4 units that is subsidized by state or federal funds that does not have an emergency backup electrical generation to have an emergency plan in place for an in-person wellbeing check for the occupant of each unit within 6 hours of an unplanned continued loss of electric power. So you heard during the public hearing that the sponsor is looking for new construction to have generators and existing buildings to have wellbeing checks. The bill doesn't state whether new construction must have a generator for all or part of the program. His concern is the residents and where they live. It seems to be about elevators. And there was questions about the backup power in buildings, housing with multiple floors when residents live on upper floors. So first of all, section 1 of the bill, this is the part that relates to existing property. I think that's right. Let me just look at this, make sure I'm actually not getting that backwards. Yes, this is the existing property. It, for some reason, is drafted in Title 14, which is court procedure, and it's Chapter 710, and this is the chapter that governs landlord-tenant law. I don't think that that is the intent here. There's a lot of things about, you know, protecting residents and tenants and so on, but I really don't think that, given what we heard at the public hearing, that this is in the right place. And then the second question, which relates to that, is whether senior housing facility has a definition. And of course, in that title, it doesn't. But there is a definition of senior housing in Title 36 that looks like this. Senior housing means multi-family, affordable rental housing units serving seniors that receive funding and project-based rental assistance under the U.S. Department of Agriculture, Office of Rural Development, Rural Housing Service Rural Development Program, or HUD, Multifamily Elderly Housing Program, or that meets the definition of housing for older persons under the Federal Fair Housing Act and the Maine Human Rights Act. So I did reach out to a couple of people about this definition and whether you could use this definition if the intent is housing for older adults where there is a high degree of independence, not licensed facilities with 24-hour housing, because that type of housing is often subsidized and that their rent is capped at percentage of income. And the way it is drafted is about people being subsidized or units being subsidized in some way. Maine Housing also agreed that that covered it. The senior housing definition for multifamily affordable housing covers everything that is subsidized, while housing for older person covers all that and more, covering anything that is intended for people 55 or older. And we read that to mean it would both include assisted living and age-restricted, which is a term I wasn't familiar with, independent living apartments. So I also asked what exactly is intended by subsidized or state or federal funds. I mean, that's a question for you. As I mentioned, this is drafted in Title 14, but the testimony suggests a broader intent, but I did also send that question out. And licensing said that several licensed adult family care and assisted housing facilities have a mix of private pay and Maine care funded residents within their facilities. And Maine Housing said you have some facilities where some tenants hold Section 8 vouchers while others pay a higher market rate rent in the same facility. The point is here that you have some senior housing that is mixed in terms of who is living in it. It wasn't clear to me, but it may well be clear to the sponsor why the wellbeing check for existing properties is within 6 hours for the existing properties, but 2 hours for those with a generator. That may be intentional, but I'm not really sure. And then the other drafting question that I had in addition to the Title 14 that kind of sticks out to me is, I don't know what hosts an assisted living housing program means. I think I know what it's supposed to mean, given that not all assisted housing is licensed. So assisted housing programs are governed by Title 22, Chapter 1664, which is where the Section 2 of the bill is placed. This is the part about new housing. And there is a definition of, of assisted housing. The way this is drafted, assisted housing program means an independent housing with services program, an assisted housing program, or a program of housing and services provided by a residential care facility. So I just want you to see that this says assisted housing program, and that does pick up all of those. So this definition of assisted housing pulls in these other definitions that are also in that chapter. And you can see those there. I just listed them out for you. So licensing, assisted housing in the broad term in statute encompasses assisted living, apartment style residences with kitchenettes, and residential care, PNMI facilities, which tend to be more dormitory style rooms with congregate dining. That is not Bill Monteo's fault, that would be mine. Activity and living room setup. And not all assisted living facilities are licensed. Some elderly housing residences provide the housing, meals, and require the residents to contract with a separate company for personal care services to circumvent the licensure process. So the reason that we have all of that there is because I think maybe that's the reason for the term hosts, but I still don't think it's the right word. I think it sounds very peculiar. So those are the drafting issues. And then the questions about safety that currently exist for new construction and existing facilities. So there is the answer from licensing about licensed assisted housing facilities with routine life safety inspections by the fire marshal's office. The inspection standards vary by the building construction type, use, and occupancy. And if the intent for the emergency generator is to ensure the health and safety of the residents by having a source of electricity in an emergency to provide heat, cooling, food, power, etc. The need for a generator is based on the anticipated needs of the residents and the anticipated challenges for evacuation and safe placement of residents in an emergency in comparison to the benefits of having a generator and being able to shelter in place. Newly constructed assisted living housing facilities are required to have a state fire marshal inspection and approval to occupy before they can be inhabited. And the current rules do not require a backup generator, only a plan for how to handle a loss of electricity situation and to include planning for alternative power needs. Main Housing said that the 4-story generator requirement is correct, that most senior facilities outside of Portland are not that tall. And as you heard during the public hearing, this is primarily intended to assure that elevators operate all the time. And then whether there are requirements for well checks, and this is from DLC as well. The only requirement for general well checks would be found in resident service plans based on an identified need, and it would be specific for the client. So the takeaway for all of this is that there are a bunch of drafting issues here. If you want to move forward, it might be useful if you don't look at the language in the bill and decide what you actually want, and we can go from there.
Any thoughts related to that analysis? So as to intent, let's start there. What's the set? Oh, there is Representative Babbage has joined us. Welcome, sir. You're still muted.
I'm sorry. Thank you very much, Senator. I appreciate it. I have been listening to the last probably half of Ms. Broom's summary, and I appreciate the work she's done in order to do that. I have been trying to negotiate what my committee's meeting today, but I've been trying occasionally to negotiate the International Business Code. And I am very frustrated because every time I found the place referred, they referred me to a different citation. And it was mostly about the quality of cable and things of that sort. So I never got the information that I really wanted. But anyway, and I want to explain one thing. I think I had indicated that the bill to me was basically 3 sentences, compound, complex, admittedly, maybe, but that they were of importance to me in the order that they were presented. And actually, I was incorrect on that. I had written the bill with priorities 1, 2, and 3. And because of the place the reviser's office decided to put it in the law, they actually had my 3rd place priority listed first, which would be just senior housing, wellness check for senior housing. That actually was an addition to the bill in order to address another legislator's concern. But that may be better left up to licensure than pursuing that here. My main hope in pursuing this bill is that folks who are in an assisted living facility do have access to backup power. For egress, I would think certainly on the second and third floors, but if they're in assisted living, they are disabled or potentially disabled in some way, and I thought it was important that they not go through the anxiety and potential safety issues of not having backup power.
Okay.
So that's the focus of what I'm trying to achieve here.
So let's start with definitions. And your intent when you mentioned assisted living with power, that's for new construction, is that right?
It is.
And it's specific to people who are in what is classically referred to as assisted living versus assisted housing.
The reviser chose to use assisted housing program.
Yep.
But I knew assisted living was in the law, and I didn't know if those are interchangeable, Senator.
Okay,
The word hosts, I can't tell you if the word hosts is mine or not. This was drafted so long ago. Sorry about that.
Okay. So assisted housing program would include independent housing with services, and assisted living program or a program of housing and services provided by a residential care facility. So those are all folks who are higher need than independent apartment.
Exactly.
And that's the group that you'd like to capture for future new construction.
Yes.
To include a generator.
Exactly.
Okay. Does that help answer that particular question on that particular item, Anna?
Yeah, I think what you're saying when you're talking about the new construction part is you're talking about assisted living and independent housing with services programs, right? Because those are the two that say private apartments.
And that isn't assisted housing program subsume the categories we care about?
Assisted housing sucks them all in, including PNMIs. I think what you're saying is you want, I'm just going to pull it back up again so you can see it.
So I'm responding to the sponsor saying it's people who have diminished mobility that he's most concerned in protecting. Is that what I heard, Representative Babbage?
Yes. If you recall, the constituent that brought this
Oh,
issue
yeah.
to my attention. Yeah.
Yeah, nobody's going to forget that story. No,
But
I think
she-
we're all on the same page about that.
She was unable to move because of a recliner
Yeah.
that was power generated.
Can you
Did
go
she live in
one
a
page-
private apartment?
She was housed in a private apartment in a private room or private apartment. I'm not sure, in an assisted living facility.
Okay, but that makes a big difference because private apartments are these 4 and 6, but residential facilities probably have their own room, but have common areas. So that would mean that if you wanted to include that, then you would be doing assisted housing program, which is how it's drafted, which sucks them all in.
I think she did not have independent food facilities. She didn't have a kitchen, that type of thing. It was. But I do know that I think we have a facility in town here who does also have apartments that provide assisted services. They're actually a very large facility, and they have almost neighborhoods. And one of them is for private apartments that also have the benefits of assisted living. So I suppose there are categories that fudge definition a little bit here, but I'm not.
And that's why I went with the description of the individual and their capabilities, and we'll work backward to a description of who that includes. Representative Perry, you had your hand up?
Yeah, as we're discussing this, I think what we may be describing is people living in a congregate living situation. That would be the PNMI assisted living programs, not apartments, nursing homes, the kind of a congregate living, I think, that you're describing, Representative Babbage.
Yes.
Representative Stover, and then we'll go to Anna.
I really don't want to make this murkier because I think all these facilities need a generator. But I'm thinking up the road from here is a very large, it's an apartment, multi-apartment, mixed use. So there's family and there's elders. And I have a gentleman that I visit up there who has developmental disabilities, and he has in-home support. So he would qualify because he gets services within his apartment, but he's not that other group of congregate living kind of folks. So it gets, these definitions in my mind get really crazy. I wish we didn't have to pick which kind of housing other than somebody who shouldn't be left alone in a power outage. Thank you.
So we'll get back to Anna. We're not any closer to establishing a descriptor or a phrase to capture these people, Anna. Is that?
No, because I heard some people talk about apartments, and then I heard Representative Perry talk about PNMIs. So the way it's drafted, it includes all of them, and maybe that's what you want, but and that's different from Representative Stover's. I don't even know where to go there. So I haven't heard you decide, no.
So as a friendly amendment, I would propose, yes, Senator Moore.
What I'm hearing sounds to me like it would be exactly as it's drafted, assisted housing program, because that includes all of them. And I think that's what we're trying to get to. I think Representative Babbage.
Okay, that's where I was going to go with my amendment. You got there first. I think we ought to cast a broad net. We're talking about new construction. We're not hamstringing anybody who exists now. We're talking about new construction. So let's cast a broad net and capture the folks who might be physically less capable in terms of getting around. Okay, so that's the definitions part. And that would be specific to new construction. Would that meet, is that your highest priority, sir?
It is.
Okay. So, Anna, we can capture that as part one and priority one or whatever. Okay. You also mentioned wellness checks. Is that something you'd like to pursue a little bit more? And
well, the reason I mentioned wellness checks is, what about all those folks that are in 2 or 3 story buildings, or even single story buildings of existing assisted living facilities?
Mm-hmm.
I'm not rescuing them from the type of situation that we talked about in the public hearing. So I thought that at least attentiveness should be part of the policy, and there should be some responsibility taken by the landlord to make sure these assisted living people are cared for, or their immediate needs cared for, in the event of a continuous power outage. So in addressing that, I figured, perhaps if it's not already in statute, it could be in policy that there be some expressed responsibility for the welfare of residents.
Anna, is it possible that section 2 should have been drafted with the first paragraph, a facility that hosts, as number 1 and the property management as number 2? I think that's where some of the confusion comes from.
I think the problem here is that you have a couple of things going on. You have the senior housing facilities, which are the rental properties, which I think is why they put it in the rental property, even though I think it's still the wrong place.
Mm-hmm.
But then you've got these two pieces kind of shoved together in section 2 of the bill, the new construction and the existing. I still don't like the word hosts, by the way. I'm not letting you away with that yet either. But we can come back to that later once you've decided what you want. But I think you're right that it would be a lot easier to break these up into 2 sections, but both within this chapter within Title 22.
Okay, and I think then at
Is that what
first,
you asked me?
that's exactly what I asked you. Under 7864, it feels like there's 2 parts to that thing, and I don't want them overlapped. And we've agreed that a facility that hosts that paragraph, I think we've pretty much settled that one, except for the word hosts. And then the next one requires a property manager. That's not, in my mind, a whole lot different than the one above in section 1.
Well, I think it kind of is, because because you are talking about an assisted housing program now, as opposed to a senior housing facility, which you might have a rental voucher, but you're not getting services that are medical. So there's a difference between how they're subsidized. So I think what I think I'm hearing is that you're looking for some way to have wellness checks in these kinds of power outage circumstances in assisted housing programs, which covers a bunch of different types of things, as you've already discussed. So, I guess the other question, well, actually, the thing that makes it a little bit more straightforward, perhaps, is the problem with the senior housing, or the age limited, I think it was called by Maine Housing, is that you have a mix of different kinds of people in them, some of whom are subsidized and some of whom are not. In this case, some people are subsidized in the sense that they're on main care and some aren't, but it's different because you're not renting an apartment in the same way.
Right. So
You're a resident.
if we stick with assisted housing and say anybody who's responsible for an assisted housing facility has to come up with an emergency plan for loss of power, that would take care of existing structures. We would get rid of some of the other language, roll it up into that first paragraph, section 1, and then we can talk about the hours to be checked, or within what hours. Does that help?
Are you asking Anna or me?
Yeah, I don't know either, Representative.
I have to live with Anna. I started with her.
Yeah, I think you can do something like that. I think.
And would that meet your needs, Representative Babbage? Your really issue, the wellness checks piece is in existing structures where people who are less physically capable need to be checked on.
Exactly. The difference between the senior housing or age limited housing and the section 2 wellness checks with basically were able-bodied versus disabled. I was interested in addressing those in most need first. There were some residents who there are some facilities who may not have total backup power, but have a common area that has backup power, or they might have one outlet in each room that would be backed up, but not the other outlets. And a wellness check would make sure that, for instance, a power chair would be in the proper outlet, or a cell phone to be recharged would be in the proper outlet, so that if the outage is ongoing, that the residents have communication and all of that. So yes, that does address what I'm looking for.
Okay. Representative Stover. Oh, okay. Other points. So is that your second priority then, the wellness check?
For assisted living, yes.
Okay.
Current existed.
And your third priority would have been would be senior housing, independent of the individual's capabilities, largely independent living.
Yes. That was brought to my attention by a different legislator who had a great deal of testimony by seniors who actually I think the event happened in Bethel, but for a lot of seniors who were with prolonged outage that affected their lives negatively, and they thought this would be a good idea.
And you want to broaden the scope of that to include a different category of people than in section 2, which we settled on the term assisted housing programs.
It is a lower priority, but those people obviously were distressed. And if there's a means of us addressing that, that's great.
I think we could do that with much the same language and use the definitions of housing that don't require supported care or provision of services. There must be a term for that somewhere. Independent apartments, independent living, congregate living. Anna can help us out there. Have you got a term that fits the category of people?
I'm a little lost as to what you're talking about now.
Okay. So
I think if you're talking about independent, I mean, the way that the senior housing language actually works, it just doesn't work where it is and it's not defined. But I mean, if that's what you're looking for, you can do that. It just doesn't go here. I don't know where it goes yet, but that doesn't matter. But that's different, I think.
And what I heard was that the senior housing was the preferred term for the top paragraph, section 1.
Age limited, I think she said.
I'm just going to bring it back up again. There is a definition in Title 36, and this is the one that I ran by ODES and whoops, sorry, forgot to turn on that button that makes it scroll. So this is the definition that we have now of senior housing, which means multifamily affordable rental housing units serving seniors. So they receive some funding. It would need to have, it also has housing for older persons, which is, I guess, age limited might be the new term we use for older persons. But this senior housing sweeps it up. My point was that senior housing is not defined where it is in the bill.
Right.
But there is a definition available that you could use if that's what you're looking for.
If I may, Mr. Chair?
Please.
What I'm looking for is for landlords who have some state subsidy to accept some responsibility for the welfare of their residents in an emergency. That's where this is coming from. My primary concern is those who are disabled in some way that may be in an assisted living facility, and the senior housing would expand it greatly. And I would love if we can come up with wording that would address that. That would be wonderful, but I don't want it to jeopardize the bill as far as achieving this for assisted living residents.
So how about if we included a description of any housing for which there is federal or state subsidy that includes seniors should have a plan. Yes, Anna?
I don't think, and I'm really quite sorry that main housing isn't here. I know that they're in several places at once, but my understanding from main housing is that there are facilities where some tenants hold Section 8 vouchers, while others pay a market rate rent in the same facility. I only bring this up because Representative Babbage specifically said state subsidy, and I don't think there are any.
I mean, there's nothing wrong with putting state and federal subsidy. I'm only saying that Representative Babbage specifically just mentioned state subsidy, and I don't think there is a state housing subsidy. I think there are only federal ones, which is what you said, Senator Claxton.
Yes.
Oh, Holly's going to, I mean, Representative Stover's going to correct me. I can see it
And then
now.
I'll go to Representative Meyer.
Not correct you, it's BRAP. BRAP is paid out of general fund. Bridging Rental Assistance Program under OBH, but it doesn't matter.
So if there are folks that are on BRAP that are living in senior housing,
It might, but when you get to, the question is, in all of my grants that I write, I have to define what senior is. So we can pick a number. That's what my advice would be. Pick a number. I use it. I go low with my grants so I can include more people.
Representative Meyer.
Thank you, Mr. Chair. The facilities that we're considering catching in this LD, are they not already licensed by the state? And is within that licensure a requirement to have an emergency policy?
so putting aside senior housing, because I don't know really honestly anything about that, because I don't think that is licensed. I asked that question to Bill specifically about whether they were all licensed assisted housing, and he said that there were also, he said not all assisted living facilities are licensed. Some elderly housing residences provide the housing, meals, and require residents to contract with a separate company for personal care services to circumvent the licensure process. Because I had assumed that too, Representative, but I guess there are these ones that are, they go through a personal care services. But I mean, we can still capture that, I think, without using the word host. But I don't know if you're asking me about senior housing, which I really don't think so. But I don't honestly know that. I'd be surprised only because there are a lot of independent people who are just living in senior housing and they're not on any kind of, they're not receiving any services and they're not receiving any subsidy. They just happen to qualify by virtue of their age and they can pay their rent.
Thank you.
So yeah, I'm looking for some way to constrain this a little bit too, to the population we want to capture. Because I do think there's a very good rationale for a wellness check program in the facilities that we're going to be living with for the unknown future because they're not new construction. And some of those folks are going to be less mobile. So senior housing is the best term I've seen so far. That includes multifamily, which I think may be a proxy for congregate that Representative Perry brought up before. Is that an equivalent term, multifamily and congregate? In some ways, probably they overlap.
Multifamily connotes a different look than I think of congregate.
Okay, so I'll rephrase it. Is there a problem with using senior housing as the group for whom we want to define some wellness check frequency? Yes, Representative Craven.
Thank you, Mr. Chair. That sounds fine to me. It would. I wonder why the fire marshal wouldn't have made a check for any of those buildings where there are multiple.
And I think, that's the challenge of hearing a bill that arguably could be heard in housing or related to licensure, which started off here because of the involvement with.
I wish I had remembered to ask for the fire marshal to have checked in before. So because that they check for safety in senior housing and in congregate housing. But then again, they're probably all licensed.
So that's an unresolved question. Is there a category of houses that aren't inspected that we haven't captured or described yet? Because and does the inspection include safe egress assessment and electrical assessment? I can't answer any of those questions.
But all of these would be some sort of congregate housing, would they not?
Yeah, but we don't want to use that term because we don't want to pull in people who
Right.
who are all just living together in congregate housing, but aren't challenged at all and live free and independent lives without any sort of support.
Exactly.
And that's why I initially went to any housing that involves people who get governmental support. But that could be Medicaid, and you could be, then we need an age description. 35 on Medicaid.
Oh, we could make it Medicare.
Okay, we can use Medicare. Yes, Representative Craven, I'm stuck.
No, there are a lot of young people who have physical disabilities that live in those congregate housing. So the age thing really doesn't fit. They may be using wheelchairs, or they may be may have other physical needs, and even in nursing homes, we have a lot of young people living in them.
How
I
about?
think what we're also trying to assess, aren't we, is the owner's or landlord's responsibility.
So
some facilities, I would say there would be more landlord responsibility than others, depending on the type of resident they may have.
So who's responsible for housing? It sounds like it's HUD, so it's HHS, right? DHHS, who's responsible for subsidized housing with multiple different ways of getting there, like through main housing and stuff. I'm looking to send a letter. Okay, so my plan B is to send a letter to a responsible entity to say this issue came up in the conversation, and how do we best address wellness checks in facilities where there aren't live-in resources? Something to that effect. I think that's the only way we're going to get to an answer on this one, because none of us know enough about codes, inspections, and building requirements. In the interest of moving things along. Representative Meyer.
Yes. So on these facilities that are unlicensed or not well regulated, who would enforce a policy? Who would enforce wellness checks? Where would that oversight come from to ensure that wellness checks are done under what circumstances?
Add that to the list of things we don't know. Representative Perry.
The only thing I can think of in terms of a way to create a regulation that would be followed up would be in licensing.
Yep.
So we're now back to talking about licensed facilities. And that would certainly include homes for the disabled, and other, and I hate to call it congregate living, but this is where a lot of people are in the same place. Facilities that are licensed, because the only real way we can monitor that is through licensing.
And so let's accept that we can't get 100% of the population that we want to get to, and make some dents until we know more about it, or give it to somebody else to do. I think that's a good approach. Representative Craven.
I just wanted to say that during the ice storm, it was MEMA that did the well checks. I remember that.
Yes, Representative Zager.
Thank you, Mr. Chair. I'm wondering if the long-term care ombuds an ombudsperson might have a role in this. It seems that the awful index story that Representative Babbage brought up there were a couple different contributing factors that led to that outcome, that awful. And I concur with the parents' sentiment of where things are going in this committee with regard to that they're not fully within our expertise or jurisdiction per se, and with regard to wellness checks, that's such a detailed in the weeds thing, and how frequently, for what kind of, it's not like people fall into one category or another, well or not, or disabled or not. There's whole spectrums of things. As far as the new construction, that's something though that we could perhaps sink our teeth into with legislation. So I guess I'm wondering if the long-term care ombudsman program might play a role in the wellness check concern.
Okay. Yeah, I'm still leaning towards a letter to get us out of this stuck spot because we don't have the expertise, and just identify this is something that's come up. We could try it for license. I mean, we could certainly make it for licensed facilities. Let's do it for that, and then send a letter for the others. How does that sound? We would stipulate that there was a wellness check plan in place for every licensed facility, and leave it to the people who know what they're talking about to set up the rules. How does that sound, Sam? Representative Zager?
I wasn't sure if you were addressing me on those questions, Mr. Chair. Thank you. I think I agree with the letter. I was supposing that the ombudsman might be a person, or maybe the licensing.
Well, we can certainly include her for any input that she might offer us in terms of where to go with this. Okay. Representative Craven?
Thank you, Mr. Chair. I'm fine with the letter, but I noticed Molly's here.
Oh, hi, Molly. So have you been privy to any of this conversation, Molly?
I have. I've been lurking, and
okay. So we've agreed on a couple things. We're stuck on trying to figure out how to get wellness checks established for the people who might need them. Any thoughts?
No, not really. I think the thoughts that I have are largely that there's not, one of the things that licensing does is require written plans for situations like this. And those do exist in licensed facilities. I think the challenge is that so many of these are unlicensed. And I'm repeating to you a lot of the things that you've noted already, but without standing up a new program, either to do this oversight over non-licensed facilities, which, working with landlords is generally out of our wheelhouse. So that might be a concern, but, or having, DHHS or contracted staff do that work. I'm not entirely sure how we would fit that into our sort of current programming.
So, yeah, and there probably isn't a professional association of unlicensed boarding homes or congregate housing. I'm just guessing. So what I understood that we had resolved so far was that future construction of assisted housing program facilities would require a generator. Mandating a generator in new construction. Are we good on that one? Yeah. Okay. Molly?
One of the things that Maine Housing had raised was that there isn't a lot of new construction. And so I think you might want to be clear about whether you mean the establishment of new facilities or literally new from the ground construction, because often these facilities are, buildings that are purchased and retrofitted or developed. And so I just throw that out for your consideration to be clear on whether you're meaning literally new construction or new establishment of a facility or living place.
Now we can talk about major renovations as opposed to upgrades, as opposed to new buildings. Representative Perry.
Well, I like new facilities because I've seen really some very good work done by people who are retrofitting a facility for an assisted living. And if they can do that kind of work while they're doing that work, adding the generator to it makes sense.
So you're talking about using language of new facilities? Yes. Okay. So power generation for new facilities in the assisted housing program category. Are we okay with that? All right. I've lost, yes, Representative Meyer.
So these are licensed, regulated facilities.
Well, these are independent housing with service programs, assisted living programs, and programs of housing and services provided by ResCare facility. I assume those are all licensed, unless somebody wants to correct me. No, that's not true, because so the only way we have any enforcement is if there's a license involved. So how about the licensed assisted housing programs?
Is that true, Molly? Do you know? I thought that, or it depends how you're doing it. If you're talking about brand new buildings versus retrofitting, there is a brand new building. I'm really casting back to days in criminal justice, which are a long time ago, but I think there are fire marshal inspections and occupancy permits and things like that. And so if you were talking about building a new building, I think you could get that without, I hope I'm not making a mistake here, I think you could do that without the licensing issue. If you're talking about retrofitting, that's a whole different ballgame. And now I'm out of my depth. And I had understood the sponsor to say during the public hearing that he had, and please tell me, Representative Babbage, if I'm misremembering, but you specifically mentioned how you had heard retrofitting was quite expensive, and I thought, so I concentrated my bill analysis on new construction because I thought that's where we were going.
I listened to Eric Jorgensen, the Honorable Eric Jorgensen, who, with Maine Housing, and he had testified on the other bill that I referenced that was just about seniors, or the concern that they had. He said that new projects, the opportunity to plan and incorporate generating capacity is the simplest and most cost-effective. The wiring can be designed appropriately. The cost of equipment can be rolled into the overall financing of the project. Life safety codes already specify that buildings of a certain height need to have a backup generator. That's a pretty significant height, unfortunately. And many new buildings already have them work into their plans. He did say that it could be $30,000 to $40,000 for a project with new construction. He mentioned that retrofitting is much higher, although he gave me a couple of examples that, well, one was higher. An 80-unit elderly complex purchased a generator for the back of the building that cost $79,000. And so, but I don't have a lot of detail on the retrofitting. It's just that obviously that would be much more involved and would include new wiring and things of that sort.
Okay, so two thoughts. Let's stick with new construction because that's easier. Brand new construction, because we can't deal with retrofitting. And then the other issue is, can anybody think of a way to address the index case concerns that prompted this conversation to start? And if if the woman in question is living in a non-licensed facility, I don't know how we can get there from here.
Can't.
We can't, there's no enforcement.
Can't.
Unless we go to the housing world and we change building codes. That's not our province. So I'm trying to come back to the index case, Representative Babbage, and trying to figure out how to address that issue. And I'm stuck. Representative Stover?
Was she in a, was she in like it was a setting of many apartments for different purposes? So in your town, they would have had to have a certificate of occupancy, but they'd also have to have let's just say fire plan. They have to have a fire exit plan. They have to post it in the hallway. I mean, they have plans for emergencies.
So are we lobbying for adding a wellness check on terms of their emergency plan?
That becomes a licensing sort of thing. And
Exactly.
an unlicensed place doesn't get that.
That's what I think too.
Exactly. So should we try and craft wellness checks for licensed facilities? Yes, Representative Craven.
I think the licensed facilities already have all kinds of safety measures in place. And so it would be just, I mean, they are required to do all this work already. So just adding another little layer on top of that would be, duplicative.
And we don't know about the circumstances well enough or specifically enough about the index case. Representative Perry?
I guess what I'm looking at is if we're going to send a letter, let's send a letter to ask about what licensing, to come to us about what licensing does in terms of an emergency of electrical or something outage, and what they're required to do. And I think we need a better understanding anyway. And
Okay.
I don't think we can make any regulations with what we don't know.
Okay. So at this point, Representative Babbage, is your hand up again?
Well, thank you. Yes, and I support what Representative Perry just said as far as, I mean, there were multiple factors in this consideration. This facility also is kind of complex because there's this sort of semi-independent living and there is a residential living in a large building and there are apartments which they also provide assisted living and a common meal. So the difficulty there, I mean, a lot of these places, her facility was an excellent facility. She had a pendant around her neck in which to press for help. It was responded to initially. They just gave her a throw blanket and went away. And unfortunately, for the next 6 hours, nobody responded to that. But I'm thinking that in a place, she would not have needed that assistance had she been able to get out of her chair. So the idea of having a backup power, or I think the wellness check would help her to negotiate, be able to be independent after the fact. It wasn't done in this case. That's complicating circumstances, and I think this might be best addressed through licensure.
Okay, Representative Jaeger.
Hey, Mr. Chair, I'm concerned that the tools available to us are just too blunt to fix that specific concern. And so I'm really not comfortable that we're going to do more good than harm if we try to make sure that 6 hour period did not happen in the way that it did, in terms of frequency of wellness checks and so forth. It's plausible that, it makes sense to me that somebody's oxygen or their telemetry system should not be turned off just because we happen to live in the state which I think has the worst power outage rate in the country. And so I really, my feeling is that we should really focus on the power issue, not the wellness checks.
Okay, so that leaves us for right now with a bill that would mandate the inclusion of a generator in any new construction. Do we even want to go there, or do we want to deal with license? Do we want to invite the Board of Licensure to come tell us what we need to be doing? Representative Meyer?
I would agree with the latter. I think this committee would be well served by learning more. I agree with the letter and an invitation to those who clearly know more than all of us on an important issue. I thank the good representative from Kennebunk for bringing this forward and letting us, giving us the insight into what your constituent endured. But I would respectfully move ought not to pass.
With the understanding that we would be inviting the
Yes.
Department of Licensure to educate us and summarize some of our concerns that have been surfaced in the conversation.
Absolutely.
All right, I've heard a motion. Is there a second for that motion?
Second that.
Several seconds, okay. So that doesn't, any other discussion? There's a motion on the floor ought not to pass. It's been seconded. One of the things you learn about what you don't know, you learn more about what you don't know. I feel like we took a shot at Representative Babbage. We've discovered it's a tough one and it deserves attention, but we aren't at a place where we can give it the attention it needs and be helpful in the process. So thank you for bringing it forward.
Thank you very much for the committee's discussion and giving it the time that you have. I appreciate it very much.
Carrie, do you want to collect the vote?
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin. Representative Griffin is absent. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 8 yes, 5 absent.
Very good. So I appreciate the committee's hanging in there to get that done so that Representative Babbage can get to what he needs to. I'm proposing a break at this point for something more resembling lunch than we managed before in the 15-minute window. It's now 2:13. Is half an hour, 2:45 with the remaining 4 bills? Half an hour, Representative Meyer?
Thank you, Mr. Chair. The committee Democrats will need to caucus at some point over that half hour. The remaining bills we didn't get to this morning.
Yeah, so why don't we try and recaucus in 10 minutes and we'll reconvene the committee at 2:45. Okay.
Turn off mute yourself.
Hi, Senator Moore.
Hey there, Zager, Representative Zager. Y'all are coming back?
Well, I actually just came from testimonies, testifying
Okay.
in the committee again. So I guess I'm early for the party.
Well, they took a short break. They were going to caucus in 10 minutes and they were going to be back by 2:45, and obviously that hasn't happened.
I feel like the Democrats do this a lot. I apologize.
We actually caucused this morning at 9:30 and we got through all of them today. So I don't know.
I think you figured something out.
Well,
probably
I think the extra 3 people might make a difference too, when you're trying to caucus.
it could be. I'm going to step out. See you shortly.
Okay. Bye now, Sam. There he is. Yeah.
Hey there, Doc. Hello there. How are you doing, Senator?
Oh, ready to get going.
We just held up so that you could give us a bad time.
I know.
All right, 1, 2, 3, 4, 5, 6. Are you waving, Representative Griffin?
No, my internet went out before I could do that vote, before you all went for lunch.
Oh, yeah, mine went out before that. So
Yeah,
do you want to register your vote before we proceed?
please. So it's LD 1657, right, Carrie?
You all set, Carrie?
So it's, the motion was ought not to pass.
Yes.
So yes. And that's with a letter?
Yeah.
Yes.
Thank you.
Thank you.
Can I record my votes as well?
Sure.
Which ones, do you want to go through the list, Carrie, of ones I?
Sure. Give me
I think
just
it's
a moment.
96 and 97 and 674. Carrie.
Okay.
And 653.
Okay.
Yes. So the first one is 653.
Is it 653 or 1653?
1653. Thank you.
And what was the vote on that?
The motion was ought to pass.
Mhm. And was that unanimous?
Mhm.
Okay, so I vote ought to pass.
Okay. The next one is 196. The motion was ought not to pass, and that's currently unanimous.
Yeah, I'll vote ought not to pass.
Okay. Next is LD 197. The motion was ought to pass as amended, and that is currently unanimous.
Okay, I'll vote ought to pass as amended.
Okay.
And were there any others?
674.
674, the motion was ought to pass as amended, and that is currently unanimous.
Okay, and I'll vote ought to pass as amended.
Okay.
Thank you very much. I appreciate your time.
And I still need 1657.
1657.
Yeah, we jumped ahead into the afternoon.
Okay, what was the vote on that?
That it was ought not to pass. Unanimous so far with the sending of a letter.
Okay, then I will vote ought not to pass in the same fashion.
Okay, thank you. That's all of them.
Thank you.
Great. And I'll just say it on mic as long as we're all here. We got some serious kudos for how quickly bill reports are coming out of committee, and some real very, very positive feedback from multiple sources about our own Carrie Withy and her amazing job. So I do think it's worth recognizing stuff like that every once in a while. So
Thank you very much. I'm very appreciative.
Senator,
all
could
right,
you pass back for us that they can't steal her?
we're doing our best, but it's not working. All right, so For those of you just joining us, this is our afternoon session that was supposed to have started 2 hours ago for the Joint Standing Committee on Health and Human Services. We have 4 more bills to consider on today's agenda. And I think were there some amendment reviews? No, good. All right. So with that in mind, let's proceed to consideration of LD 1649.
All right, LD 1649. This is an act to make the shared living program accessible for persons with intellectual disabilities or autism. This bill authorizes payment from the DHHS Community-Based Services Contingency Fund for home accessibility adaptations to shared living residences. It also requires the department to convene a working group to evaluate whether to modify the shared living program for persons with ID or autism to provide different stipend rates to shared living providers based on the needs of the person served. It also has a definition of shared living residence in there. So you heard from the sponsor. LD 1944 from last year was a similar bill. That was Representative Kepler's bill. The constituent has now moved after the shared living house was sold that he was living in. So now is in Senator Libby's district. That property had been modified with the shower to allow for his needs, and now he's unable to get a modification in his new shared living arrangement. And the bill is to change the rules to allow for home modifications in shared living residences, regardless of who owns the home. Disability Rights Maine rates to shared living providers do not vary based on the needs of the individual being served. That's the group, I guess. And the current law and rule allow for modifications only in homes owned by the individual and not by the shared living provider. So that's the other piece of the bill. And the department reimbursement measures are already in place for home accessibility adaptations. The department contracts with a main care provider who provides the oversight to independent contracted shared living providers. And the shared living residence definition in the bill doesn't reflect that the department does not directly reimburse the shared living providers. And the funding for modifications could be provided in the administrative cost that the oversight provider receives for an individual. And then just a reminder of that drafting concern about the language in line 5 and 6, because the department doesn't contract with the shared living provider, that definition doesn't actually work. You had a couple of questions. You asked for some information about the contingency fund, and Paul has provided that. I don't know whether you want me to read that or not. And then you also asked about the provider who received the funding for the home modification and whether they had to return the funding and what happened to that funding. And you can see there the response from Paul was that the deposit for the work had been made but not spent, and that money was returned to the department, and it could be reused for that purpose. The issue isn't funding, it's policy. And that's because the oversight agency is responsible for ensuring accessibility among its shared living contractors. I don't know whether you want me to read Paul's response there. I'm pretty sure he's here in addition to Molly.
Yeah, he is. He's
so
in the room now.
I'm just going to get right out of the way here.
So, listening to Anna's presentation, does that raise any questions, any clarification requests? All right. I see we're joined by Director Saucier. Welcome, sir. And my understanding is that the department, you may have a amendment for us.
Yes, we do think this is a great opportunity to broaden eligibility for, special uses out of the contingency fund. The language there was quite old, and it referenced I believe the history is probably that it referenced the types of arrangements that we had at the time it was drafted. And so we would recommend that we just move away from the language of contingency expenditures being tied to a particular setting and instead tie it to the individuals who are served. which is also consistent with our policy generally. It's not the building or the provider that's eligible, it's the person. And so that's what we would recommend doing here.
So anybody getting Section 19 assistance would be able to access the contingency fund?
It would actually be 21.
I'm sorry.
It would be different waivers, but basically this is in Chapter 5, which is the intellectual disability and autism chapter of 34B. And so what I would suggest is that the fund be used for anybody who qualifies for services under this chapter, and that regardless of where they live.
Oh, okay. And can you speak to how much money there is in the contingency fund?
$300,000. I think actually my COO sent me a note a minute ago. It's $302,000, but that's what's in there now. We use it rarely. We're pretty judicious with it. Other examples of use of the account, burial for members who didn't otherwise have funeral expenses taken care of and so on, certainly could be used for this purpose. I think the issue in this case has really never been money. It's really the policy. And, I don't really want to get into talking too much about the individual who requested the bill, but it's a very complicated individual situation. And obviously the policy hazard here is because any consumer has choice in our system, and we want to maintain that. They don't need to stay with a particular provider. And so, you can imagine a scenario where a modification is made, the consumer decides they don't like that provider anymore, they want to move on. Now you're facing another modification because you can't take it with you. In the particular instance, this is a person who we are very much engaged with and appreciate actually all of his suggestions. We've already modified shared living under our emergency Appendix K for purposes of being able to incentivize a second person in a shared living to accommodate his partner. And because we think that's a good policy. And we are willing to keep working with him on this particular issue. But it is complicated. It's really not a matter of us refusing to pay or anything like that.
Okay. I didn't see we've been joined by Senator Libby. Did you hear any of Anna's analysis or have any response?
I wondered if someone could send me the amendment. I've not seen it yet. And Mr. Chair, I wondered if I could pose a question to Director Saucier.
Oh, sure.
Director Saucier, if we were to enact the languages that you've presented, and we have the case of a person in a shared living situation where a modification was done, the owner of the property had to sell for whatever reason. With this new language, would that individual who is the beneficiary of the modification be able to tap the resources of the program at their next home?
I think that's really the question. That's the key policy question where, once you've invested in a particular home and then what do you do? I mean, I'm not sure if you're suggesting, for example, that the modification would be funded contingent on the owner returning the funds should they sell the home, for example, so that we could invest them in another home. We are really interested in pushing the limits of the shared living model. And so, which is part of the reason why we've been so interested in working with this individual. And one of the needs that comes up is physical accessibility. And so our approach to the next provider is likely to be an offer to share the cost. so that there is some shared investment in it.
Are you saying your amendment does not speak to the situation I've described?
Well, what the amendment does is it very clearly then allows us to use contingency account funds for a person in shared living or in any other service that the department offers. So it doesn't, as the in statute currently, the contingency fund appears to be tied to certain types of providers, not including shared living. But the issue would be the same if it were a group home, or, the issue is who owns the home. And is the state comfortable with a policy where we're investing public resources in a private homeowner's home, and that you can't take it with you, if you will. So which is why under Medicaid policy, you can pay for any adaptation that is portable, but you cannot pay for permanent installations.
Which is why you have the contingency fund?
Which is why we have the contingency fund, because there are some instances where the case is so compelling that you want to support it. And, in the particular instance that we're discussing, again, the individual lived in a group home setting, which was far more expensive. And so it's actually cost effective for us to go ahead and make this investment, even though it's not our normal policy, because, it's what the individual wants, and it ends up being less expensive at the end of the day. So maybe applying a cost effectiveness test like what I've just described certainly applies in this case.
Are we getting close to answering your question, Senator?
I have to be honest, I'm not sure I understand what the amendment is doing. And I did come in late, and I apologize for that. If others on the committee understand my question and feel comfortable the amendment moves the ball forward, then I don't want to hold the committee up.
Representative Perry?
Let me try to explain this as looking at this. I think what we're looking at is the parameters of the program he's in terms of shared living, has limited his ability to take with him and have another adjustment done. However, we've opened up the contingency program so that shared living becomes a part of it, which it was not before, which means there are funds now to do this type of thing. And it would have to be that he would have to talk with the department around this, and the department would make a decision. But now the department has the ability to make that decision. Is that helpful?
Thank you, Representative Perry, and I'll give you the nickname Libby Whisperer from here to the end of session. I appreciate that.
The other thing it does that I like, as I heard about it, was in expanding the number of people who can access it, we're actually supporting shared living in a way that we weren't before by making some of these contingency dollars available. So I think that's a win. It certainly isn't a guarantee that what the bill's original issue gets addressed, but we certainly, that individual can now apply. And then there would be a process, but there's plenty of money in the fund, and a bunch of other folks now have access to that same money to expand their options, which I think is where the department's trying to go. People live where they want. So I think I think those changes respect that. Did you get a copy of the amendment yet?
Molly forwarded it, and I appreciate that. I've not been able to share it with the advocates, but I know the committee needs to get bills voted out. So if there's a interest in moving this amendment forward, but an understanding that maybe a floor amendment could be discussed if there's something that's missed, I don't want to hold the committee up. I just also haven't had a chance to digest this with the advocates yet.
Okay. And yes, let me just finish the other piece. The other piece to the bill that particularly stood out, Senator, was the working group on shared living. And I wanted to hear what Dr. Saucier had to say about multi-stakeholder group.
So we have a work group on innovation right now that is looking at expanding our service array. As I mentioned a few minutes ago, a very big goal of mine and others here is to expand the application of shared living. We were able to do one very important piece under Appendix K, which was to improve the incentive to have a second person in shared living when that's appropriate. So that piece is done, and we intend to make that permanent policy. What the bill specifically calls for is tiers, so that you could have levels of need and have different reimbursement rates for different levels of need. We're open to that. I like the concept. And it really is one of those innovations that in order to have integrity, in my mind, really needs to go along with a conflict-free needs assessment, which we are moving to implement. So the assessment process needs to come first, and then looking at tiers and shared living or other types of arrangements is absolutely on our radar. So that set of issues around shared living and other innovations is being addressed by our innovation work group, which includes providers, self-advocates, advocates, families.
And how often has that group met, or how much, how frequently, or how many times?
I think they have met 3 times. I would have to check and I'll confirm. And our hope is that the work will culminate in an innovation summit in the fall, a large meeting with all stakeholders, people, from out of state. For example, on tiered shared living, Connecticut has it. Bring some folks from Connecticut here. If that is, if the work group is moving in that direction, then I would expect shared living changes would be a big part of any innovations that we end up moving toward. And of course, this all really coincides with the likelihood that we're going to have significant new federal funds to improve HCBS.
And when did that group start to meet?
They started in December, I believe, or November of last year. I can get details for you, and there is an area on I'll provide information to Anna. There's an area on our website that has all of our DS work groups that are meeting and so on, and the members, et cetera.
Okay. Does that meet the spirit of Section 7 in the bill that you introduced, Senator Libby?
I think knowing that activity is happening, and at least the department willing to hear some of the voices of folks that are impacted by shared living would help address that concern. Yes, Senator Claxton.
Any other questions, comments, concerns? Any language that needs to be further clarified, Anna? Okay, Senator Moore?
Yes, it sounds like we've got this one under control, so I would make a motion to pass as amended on LD 1649 using the department's amendment that was presented to us.
I would second that.
Any further discussion? Not seeing any, we'll turn to Carrie and ask her to collect the vote.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lumlin,
Yes.
Representative Lumlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan, Representative Madigan is absent. Representative Javner, Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you, committee.
Thank you for being here, Senator. So that brings us to consideration of LD 17.
I don't have anything new for you on this. This
Oh,
is a
that's
bill
right.
that was tabled.
That's right. That's right.
This
Yep.
is creating the pilot project for section 19.
It says right here in my notes, it says on table. So I'll take, I just don't read my own notes. So I'll entertain a motion to take LD 17 off the table for consideration.
So moved.
I'll second it.
Thank you. All those in favor of taking it off the table for discussion, please so indicate. That's palms away. Thank you. All right. So I see that Senator Maxman's here. Welcome. Are you with us? There you are. Okay. All right. Anything that has changed that you want to bring up between now and the last time that you we had a work session?
Yes, thank you, Senator Claxton. A couple pieces of information. The first is that there was some confusion last time about whether the upcoming transportation study would interfere or overlap with this bill. And I forward this on to the chairs and leads, but the department has confirmed that it would not interfere and that they have, if funded, that they could implement this pilot project. And this morning we also spoke with the folks who run a similar program in New York State and got a lot of useful information from them about how their program works and who their audience is for that program. I'm happy to go into detail if needed, but I can stop there for now.
Thank you. Any comments or thoughts about this bill that we're now considering? There have been lots of discussions, lots of phone calls and contact. Has that raised any yes, Representative Zager.
Thank you, Mr. Chair. I'm very excited about this prospect. I really appreciate Senator Maxman's diligence with it. In talking with the New York State folks, though, it's not clear that we have the best evidence basis of exactly how to structure this, and so I think that there's a role that this bill could play and Maine could play in elucidating that. But I think that in order to have evidence-based policy that does the most good for Mainers, we need to have good evidence. And so my suggestion to the committee is that perhaps this study could be formally designed through, I don't know, Cutler Institute or some academic policy entity in Maine, perhaps through the department in a contracting capacity to develop a study that is described in the bill in LD 17 in the resolve. So that's my suggestion is that it be kind of refined and maybe with some sort of report back in half a year or so, and maybe in the second regular session to this committee on how that study might be designed. There's a lot of opportunity for like a terrific randomized controlled trial that could be used to demonstrate the extent to which non-medical transportation can benefit a particular population, say rural Mainers in a or any population that the study designers define. So I hope that wasn't too rambling, but I wanted to. I've been thinking a lot about this and talking with various folks, and that's where my thoughts are. Just to answer your question, Mr. Chair.
And Molly, can you clarify for us what the relationship is? Or we know there's a contract, or I think I know there's a contract with an entity to help us with this work.
I think actually what it is as part of the fiscal note, we included a funding for a contract to help do the evaluation, recognizing that we wanted, professional a professional assessment of the results.
So that's already built in. That work is that the point that Representative Zager makes was that we may need to expand the fiscal note a bit to allow the design process to be robust as the trial gets as the pilot gets launched. So would the people with whom you typically contract, would they be willing to help you with making sure the design got us some reliable data?
I might punt that one over to Paul to see if he has any ideas about who that might be.
Well, yes.
Yeah, so there is as you know, there's an evaluation going on of the NET program, and the waiver services are not the particular expertise of that vendor. So we'd have to think about whether they were the appropriate party, but I'm sure there would be parties, Representative Zager mentioned the Cutler Institute, they might be one, and I'm sure there are others. It might be the kind of thing where we'd want to go out to bid.
Okay. And the goal is to get data that's valuable enough to let us make a decision about whether to expand the pilot to other portions of the state. Representative Perry?
Yes, so I'm going to sort of work on what I understand we're talking about. First of all, we're talking about developing a study with goals and specific outcomes that we will be looking for as a result of the study. And then and how the study is designed, and then have the program go forth. And the evaluation would actually look at whether we've reached those goals, what it means not only to services and the lives of these people, but also what the cost or cost savings would be as a result of doing that. Am I correct?
Those will be some of the metrics and outcomes that I'd be interested in if I was running DHHS and wanted to know if we wanted to spend some more money. I'm just for the record, I'm not speaking for DHHS. Senator Maxima, how does that sort of approach to things? It refines a little bit what was built into the initial fiscal note. Maybe makes the design phase a little bit more robust. And basically we would be creating an allocation that would say to the department, get this work done and get started on the study when the design work is done.
I think that makes a lot of sense.
Okay, so given your experience with this kind of project, Dr. Saucier, how soon might we, I'll rephrase it, if the committee wants to follow this closely because it seems like a really important concept, would there be something to report to us in terms of process by early October, just as an update? And then again in January as a more formal update on where we were in the cycle of design, build, do, interpret.
So I'm thinking about this in real time here, but I think by October, certainly the goals of the pilot could be clearly articulated. And so you could see whether they align with what you're trying to do. And then I would say by January, there could be a vendor in place to do the work. And then a year later, the pilot would have started up. And then the evaluation results would come sometime after that, depending on how fancy an evaluation it is. I mean, typically they want, some period of data to look at.
Does having this kind of data help us make the case to the federal government when we're asking to expand something like this?
Oh, yes. Whenever you have, especially, CMS is of course concerned about policy, but they're primarily concerned about expenditures and things being cost effective. And so being able to show cost effectiveness always makes like waiver requests or state plan amendments much easier to get through.
And cost effectiveness in this case would be by launching this pilot, we've made healthcare, we've made it so that the people involved in the study are overall spending less on their healthcare than the ones who weren't in the study, coarsely.
Yeah, I think, again, I'm thinking about this in real time, but I think the objective would be, or the hypothesis would be that if you allow people to get out more, they have more socialization, they have more primary care, they have things that if they lack, their health would decline more quickly and expenditures would otherwise be higher.
Sounds like we're exploring the field of priority of social needs.
It's true. It's really the way I think a pilot would be structured would be around this is a social determinant of health. Yeah.
Okay. So we don't really need to do anything at all to the bill the way it stands, the way I'm hearing this. I'm not hearing anybody wanting to make amendments or changes. Other than to prevail upon Molly to get us an update and Dr. Saucier at some point in the fall, and then a more formal presentation when we reconvene in January. We don't have to put that in the legislation, do we? We can count on you to keep us posted.
Yes.
Okay. Molly, you had your hand up.
Yeah, if you're looking for a broader contract to do some of that design, I think having that clarity in statute would be helpful.
Okay, so you're looking for language that would help you define what you're going to the contractor for?
Or just that we should go to the contractor before the evaluation piece. Because I think that our understanding of the current, the bill as drafted was just the evaluation piece.
Let me go to the Representative Craven and then to Anna.
Actually, I was just going to make a motion, but if we're not ready, I'll take it.
Yeah, let's get a couple things refined. Anna, did you have something you wanted to clarify or question?
Yeah, one was the thing that Molly just mentioned, which is that if you were going to include that, you would want that. The second thing is all the dates would need to change, because as Paul was going through all of that, I'm writing the dates down, and I get to basically, and Paul, you can tell me if I'm wrong here, but if it was January, you were ready to go out to bid, I guess, and then a year later you would start the project. A year and a half after that it's an 18-month project, 6 months to evaluate it. We get to December 2024, 6 months, is that enough to evaluate it? So that's when you would be coming back to the legislature with a report, in addition to the interim one that you mentioned. And the other thing is, if you want something by October, you would also want to put an emergency preamble on it.
We'd be happy to just report back informally to you in October if you don't want to do that.
Okay, thank you. So we'll come back to the other points. And Representative Zager?
Thank you, Mr. Chair. I think that the timing in part depends on the variables. In other words, how the study is designed, the research questions, the outcome measures. That's stuff that the department and the vendor are going to work out. So perhaps we could leave it more open-ended, not, I recognize that the bill as drafted calls for January 2023, I think is the report date. But if maybe in statute, we could leave it more open-ended, ask for at least an interim report by a certain point. That leaves open the designers of the study to design a really good study. That's what we want, is good data from a good study.
Do you want to speak to the content of that study or the content of the contract with the vendor in terms of a little bit better definition that Anna and Molly referenced in terms of what we're looking for?
My suggestion would be that it should be a randomized controlled trial, that it be main based, and it's some sort of main, the main population, perhaps a rural population. Senator Maxman's Senate district, could be the place, or distribute, like really what I don't want to confine it too much, but I also think that the outcomes that can be looked at can be either medical and or social outcomes. Just to allow for both, and fiscal and financial outcomes could be in either of those buckets.
Okay. Senator Moore, you had your hand up.
Yes, thank you, Senator Claxton. I guess I'm a little bit confused. Am I understanding that the pilot project itself would not even be started until we got the feedback from the company with the goals and the specific outcomes and had the whole program outlined before we would start the pilot?
That's traditionally how a study is done. You set up what you're measuring and what you're looking for outcomes to make sure that what you're measuring is going to get you that information, and then you launch the study.
Well, I understand that. I guess what's throwing me off is calling it a pilot project instead of a study. That's what's bothering me, I think.
Well, and we can use the terms interchangeably. The reason I referred to it as a pilot was they were entering testimony initially. There was a conversation about arbitrarily picking 10% of the 2,550 people.
Right.
So that's where I think you can use pilot with the, maybe pilots indicates a little bit more inclination to keep going as opposed to a study for test of concept. We don't have data at this point from anybody comparable to us that I know of that tells us that this makes sense or doesn't make sense. So we want to get some good data with which to make subsequent decisions. That's really what we're trying to accomplish.
Okay. Well, then, of course, the fiscal note would be totally different than what's included with the bill.
Yes, depending upon how stringent the requirements are of the study, how many metrics, what the collection process is, all those kinds of things. So that would have to be negotiated.
Yeah, because I know in our projection, that's where we came up with the 2,550 people. And if we estimated 10% use at 2,000 per person, that's where we came up with that initial fiscal note.
Yeah.
But I'm hearing that won't even take effect probably until 2022 maybe, or 23 maybe.
Maybe, yep, 2022.
Yeah.
Yeah. And
okay.
the initial expense out of that, whatever we allocate, would be the contract with the vendor to set up the study.
Okay.
And so it will be an allocation that then the money from that allocation will be gradually dispersed over 18 months, once the study starts after the initial expense of the contract.
Right. Okay.
Does that answer some of those questions? Okay.
I think so.
Doing these studies is a big deal. We want to get it right. So how does that sound to you, Senator Maxman?
That sounds great. And also my understanding is that a lot of these details would be figured out through the DHHS process and doesn't necessarily need to be explicated in the amendment. But certainly, making it clear that that's part of the process is important.
Yeah. Okay. So do you think, Anna, that that gives Luke enough information to develop a
I think
projection?
it does, as long as you're willing to change the date that the report back comes back to you. And also because he needs to be able to figure out which bit goes where. And also we would figure out some language for the contract. It doesn't, I think that Senator Maxman is right. It doesn't need to be very specific. It just needs to basically say that the department will be contracting for the design of the study.
So January 23 would hopefully be at least close to a year into the study, plus or minus 3 or 4 months. Is that long enough to get some data or long enough to get a report?
Well, this was originally drafted for getting it at the conclusion of the study with the results. So that, to me, seems around December 24, which would be in time for that 2025 session. I think that's the one date you need to change. If you want an interim one, you can.
Okay. All right. Does that sound okay with the idea that we would like, annual follow-up or updates, not a formal report back?
You can ask them in orientation too.
Yes. Yeah. Senator Moore?
Just asking. So I just want to make sure that the department is comfortable with this and what we're asking them to do.
I would echo that what we contract for shouldn't be too specific. And so, for example, if Representative Zager is comfortable calling it quantitative analysis and evaluation, that's pretty broad and it gives us a lot of room. I'm not sure we would end up with a randomized study, for example. So
you okay without leaving out that specific? We're just talking about a robust study that produces statistically significant results. Okay. All right. I'm not seeing any other questions or comments. Yes, Representative Zager.
I was going to move, but Representative Griffin may have something for discussion before.
Representative Griffin?
Thank you. This may not be a very good question, but once we get all this information, what happens next? I mean, what's the purpose of doing the study and what are we going to do with the information? Are we going to, sorry.
Do you want to answer that, Senator Maxman?
Sure. I mean, the purpose is to try and figure out a model for providing transportation services that works for rural places. And so once this pilot happened, we would have the data and we would be able to figure out if this was a model that could continue to work for Mainers. I think, when we talk to the folks in New York, they actually have it into their waiver and into their plan of care, so there are other ways that this can happen, but this is step one in figuring out if this is what's going to work for Maine. It certainly sounds like it works really well. In New York, they're talking about how if socialization is part of a plan of care, they'll help people get to church, for example. So the question is, will it work here as well?
So as I understand it, this is the next step of trying to decide whether this is something we want to expand beyond whatever number of people are involved in the pilot. Do we want to expand this county by county, mental health region by mental health region, or over the whole state? But this would get us some data on which to make that decision. Does that make sense, Representative Griffin? Okay. Representative Zager?
Thank you, Mr. Chair. I move ought to pass as amended.
I would second that.
And the amendment is the fiscal note and a change in dates and a request for periodic follow-up. But we don't even have to include that part.
Just the contract.
And a contract to help build a robust study that was quantifiable, that would produce quantifiable results. And that should include both medical metrics and social determinants of health consideration for metrics. Anything you want to add to that, Representative Zager? It's your motion.
No, Mr. Chair. I think Director Saucier and described that well, and I think you summarized it well. That is my motion.
Was that motion seconded? I see some seconds.
Yes.
All right. Are there additional points of clarification, questions, concerns? I don't see any. So Carrie, would you collect the vote?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan, Representative Madigan is absent. Representative Javner, Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Very good. So thank you for being here, Senator. We'll see where the next steps take us. We'll be interested to see the results too.
Thank you so much.
Thank you. And thank you, Dr. Saucier, for being here and helping us with some of those issues.
Thank you very much. And I feel like I have to disclose that I'm not a doctor. I have loved having you call me Dr. Saucier, but unfortunately I don't have that degree. So I figured the longer I let it go, the harder it would be to fess up. So.
I'll use director from here, but it was a measure of respect.
Yes, and I took it that way. Thank you.
Yeah. That allows us to move on to consideration of LD 1241, which is currently on the table, Senator Moore. And I'll entertain a motion to take it off the table.
So moved.
And seconded. All those for taking it up in discussion and off the table. Thank you very much. Any additional thoughts, changes, feedback since our last visit that the committee wants to share? Senator Baldacci, you had some questions of the AG's office, didn't you? And so did you want to share those?
I was just going to say, I think we got a letter back
Okay.
from his office, but I'm prepared to go forward. It just helped clarify some issues, and I don't think it really changed anything, but I'm glad I appreciate the Attorney General's willingness to share his views of the system, to give us some background and his observations of what the standard operating procedures are currently. So I'm happy to go forward with the vote.
Did you want to put up that letter, Anna? Is that something you could do for us?
Just 1 second, just have to get to the right page. And I did just send it. Oh, I did just send it to you, Representative Fecto. And tell me when you want me to move it down, I guess. Yeah.
So
I guess the first part is mostly about what it does.
Background, right.
So I can move down.
So the second paragraph says aligns with departments. I didn't read that
Oh.
fast.
Sorry.
Aligns with department's current practices and standard operating procedures. Follow up with site visit. And the licensee receives a summary. Okay. So that was one of the concerns, was about some explicit feedback. And another about disclosing identity. I think the AG pushed back on that one. Yes. Evidentiary privilege. Okay. So those are I think those key points in that letter, if that helps anybody. So thank you for that, Anna. So Representative Fecto, any additional thoughts since the last time we were here in work session?
Thank you, Mr. Chair. Good to see the committee yet again. I really think that this is a transparency issue with Maine businesses. I'm sure each and every single one of us here have received some very confusing phone calls from local business owners. I know I have. And often business owners were left to consult with lawyers and legal teams because of the communication they received was not clear on what happens when they receive X from X communication from some sort of state department or agency. And so this one is dealing mostly with HIP. I guess I see it differently than the AG. I think if the AG and I were to compare legal credentials, I would definitely lose that 10 out of 10 times. But I do have concerns about the HIP complaint form that can be made anonymous. It's the first option you can click. And I know the rest of this information, it says that the AG's letter that some of this is within current practice, not all of it is within current practice. The stuff I saw here, this is stuff that the program would have. And so to share it is a very simple thing to do. I would, there's a few things that we may, we could amend to make this a little bit better. And that would include, instead of A, B, and C, here in section 1, it could be a copy of the HIP complaint form, if available, or A through C. But I know that the AG disagreed with that. And then essentially deleting lines 37 through 39 on page 1 and lines 1 and 2 on page 2, which were not my intent the way it was worded in the bill. I think this is stuff, and then not providing, and then my third recommendation would be amending E and F to say, pointing where on the state's websites or websites where this information is, so they're not coming with 40 photocopies of the executive orders, because I know some executive orders build on top of one another. And then some of the scientific information that's on the websites could be this thick. This is information that they have. And if it's provided easily to the business owner, it makes for a better situation, especially what their rights are, because no business owner that I spoke to knew what their rights were, how they would appeal it, or possible accommodations from how that's dealt with. And a lot of that was dealt over deal making through email and not really in a way. So I may be in a situation where I just kindly disagree with some committee members, and I may be at a legal disadvantage with the AG on being able to face your accuser. But I think most of this bill is just a fair transparency issue. Thank you.
Thank you. Any comments, questions, clarifying points to be had related to LD 1241? And this bill, just for reference, Representative Fecto was brought for, when did you put this in? Do you remember? This would have been November, December.
Sometime before cloture, I put on a lot of bills, so there's no way I could possibly remember that.
Okay, no, but I mean, it wasn't after cloture or anything, so.
This was not a late bill. No, it
Yeah,
was not.
yeah.
Mr. Chair.
Yeah. Okay, any questions, concerns? I'm not seeing any. Yes, Senator Moore, you had your hand up
Thank you.
first?
Yes, thank you, Senator Claxton. In view of how important it is, I think, for the transparencies, and I do like the proposed amendments that Representative Fecto has shown, I would make a motion of ought to pass as amended on this bill.
I second it.
So the motion's been made and seconded, ought to pass as amended. Did you catch all of those changes, Anna, as Representative Fecto went through them?
Mostly, I do just have one quick question about the A through C, I think, and you said that it would be the HIP complaint. I don't know what is on those, so I'm just at a disadvantage. I'm not saying I can or can't do that. I don't know whether that's something that has the person who complains named on it or not, or whether you are. I can't figure out whether you're sticking to the identification of the complaint or whether you're saying that the HIP complaint, I don't know, redacted or something. I'm not entirely clear, that's all. The rest of it I've got.
You want to take a shot at clarifying that for her?
Would that be me? Yeah.
Yes.
Yes, Mr. Chair. So I guess it would be a copy of the populated complaint form that they populate on the online system, but some of them may be done over phone, or the complaint have been made with an employee, so it wouldn't have been a filled out form. So it's essentially a populated form. But if they don't have that form because it wasn't populated in that manner, then A through C would be provided so long as it's legal to submit the person's name and contact information.
Representative Griffin, you had your hand up.
I do. Could we have a corner caucus, please?
Sure. Before we do that, I want to hear if we could hear from Representative Craven. You had your hand up too.
Thank you. Thank you, Mr. Chair. I'm going to be voting in opposition to this motion. In my community, businesses went way out of their way to follow the rules and to keep customers.
Oh, we just lost you, Representative Craven. Can you turn off your video? Because we're not hearing you.
I think she's lost.
I think she's gone. She's
Wear a
locked
mask.
up. We didn't hear any of that, Representative Craven. Your Wi-Fi took a vacation.
Oh, wow. Am I back now?
You're back now, yes.
So what I said was that I'll be voting in opposition to the motion because I think that businesses in my community spend time and energy keeping their facilities safe and welcoming for people to come in and be safe in their facilities. I think that when there's a facility that doesn't wear masks or that doesn't follow protocol, they deserve to be called out. And I just wanted to say that in acknowledgement for the amount of work that organizations and businesses did to keep us safe during this coronavirus.
Thank you. We've had a request for a corner caucus. Representative Griffin.
Senator Claxton, we're good. We're good. Thank you.
Okay, but I've also had a request for a corner caucus.
Oh, you did?
Nice try. Nice try. So
Okay.
how about 4:10?
Okay, sounds good.
Okay, 12 minutes.
Oh, mine, you know what I'm doing.
We're getting much better about jumping in and out of caucus and back at the like committee room.
Is that a good thing or not so good thing?
Remember how long it took in February and March to do this, or March and April?
took us about 10 minutes to get to the next place and 10 minutes to get back. And
I almost broke my hand one day. Okay, so we're back in session. Yeah, we're back in session early, just for the record. The motion on the floor is ought to pass as amended. I see no further discussion. Yes, Senator Moore.
I just wanted to make a comment, and I'm willing to do it. If the committee is having, I want to call it indigestion about keeping the nature of the complaint, the name and contact information of the complainant, and the method of submitting the complainant, I would be willing to entertain a motion or an amendment to this bill so that we can continue to have the transparency. But if that is causing some concern by the committee, I would be willing to make that amendment.
Can you run that through me, run it by me again? You'll be willing to?
Where we, in our section 3, where we had, and Representative Fecto can yay or nay me, but I believe it is A, B, and C, where we were talking about making the amendment where we would be getting the information from the populated HIP form.
Yep.
If that is a concern of the committee, then I would be willing to amend it and just leave those out altogether.
Any thoughts about that? A, B, and C are the nature of the complaint, the name and contact information of the complainant, and the method of submitting the complaint. Am I right? Is that what you're referencing, Senator Moore?
That is correct, but I would run that also by Representative Fecto as well, if he's okay.
Sure.
With it.
Representative Fecto, what do you think about that?
Thank you, Mr. Chair. I'd be amenable to that. The big thing is transparency and identifying the which executive order, the science, and then a business knowing their rights. That's a business knowing their rights on and how to proceed is the most important thing. Definitely not the name of the complainant. That's definitely not the major focus.
So how would the committee feel about bringing in somebody from HIP to explain process and how this would fit with theirs? Is that something you're interested in or not? No, I'm not hearing yes. Representative Craven.
Thank you, Mr. Chair. So this is the way I guess that I see, that I feel about this bill personally. I think that the administration and the department had to make really, really, really difficult decisions, and that businesses had to make really, really difficult decisions in their business dealings and with the department, and everything was new and nobody knew how anything was working. So I am still going to be supporting the department in their work. Thank you.
Thank you. Any other comments? I'm not seeing any. So Senator Moore, I'm reading the room as thank you for your suggestion, but not incorporating it in your motion unless somebody wants to say otherwise. So the motion stands, ought to pass as amended, not including the amendment that you just raised, Senator. Okay. So Carrie, you want to collect the vote?
Representative Zager.
No.
Representative Zager, no. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
No.
Representative Stover, no. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
no.
Representative Perry, no. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Sorry about the delay. No.
Representative Craven, no. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
No.
Representative Meyer, no. Senator Claxton,
No.
Senator Claxton, no. That's 3 yes, 6 no, and 4 absent.
Okay. So does the minority have a report?
You need a new motion.
Right. Okay. So the motion ought to pass as amended does not carry. So I'll entertain another motion, an alternative. Anybody want to make another motion?
Oh,
Representative Meyer?
Thank you, Mr. Chair. I move that LD 1241 ought not to pass.
I second.
Motion is moved and seconded. Any discussion? Ms. Withy, your turn again.
Sorry, Senator Claxton, it looks like Representative Lemlin has.
I'm sorry,
comment.
Representative Lemlin. Yes, I didn't see your hand up, sir.
Thank you, Senator. I'm just kind of shocked that the part of this committee is in favor of, this is pretty much like you're in favor of Big Brother. Just turning people in and having the businesses have no say in it and no representation. I mean, the businesses have to fight like crazy because one person says, hey, you know, I went into this restaurant and a person had a mask, but, you know, it was a little bit under their nose. And now they get turned in and their life gets turned upside down because one person decided that that was not enough for them. So I'm really surprised with what I know of this committee that they're actually going for this, but thank you.
Representative Griffin?
I just wanted to make a comment that small businesses are the backbone of our economy, and I think we need to support them. Thank you.
Thank you. Any other comments? Any hands I'm missing? Thank you for flagging that, Carrie. You can go ahead and collect the vote now.
Representative Zager,
yes.
Representative Zager, yes. Representative Lemlin,
No.
Representative Lemlin, no. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci, Senator Baldacci is absent. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
No.
Representative Griffin, no. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan, Representative Madigan is absent. Representative Javner, Representative Javner is absent. Senator Moore,
No.
Senator Moore, no. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 6 yes, 3 no, 4 absent.
So invite a minority report.
It would be ought to pass as amended, as the proposed amendment that we had.
Right. Thank you, Senator Moore.
Sure.
I'm sorry, can I just clarify it, Senator, so I know exactly what I've got, because I didn't realize you'd all started and I was out of the room, so I missed the beginning. So I know that we were deleting the end of the section 3, lines 37 to 39 in the second page. And I think I understood that. Oh, where are those letters? I'm sorry. There were 2, I'm sorry, I can't quite see on my piece of paper, but there were 2
I think it's E and F. We're on the, E and F, where on the website that information is rather than actually providing. I'm just still not entirely clear on paragraphs A through C, whether there were any changes there or not. I'm sorry to be so dim, but like I said, I was out of the room. I got no excuse for that, but I thought it was 4:10, so I messed up.
And Representative Facto can correct me if I make a mistake. What he was talking about is that if we have a populated HIP form, which is the online form that is actually filled out by the complainant, then that information could be gathered from there, or it would be provided in A, B, and C. If they took
I
it
see.
over the phone or something such as that.
Okay, so A, B, and C are basically still required.
That
Okay,
is
got it. Thank you.
And in section 3, you referred to lines 37, 38, 39.
Yeah,
That's
I got
actually
that. I started with that. Yep. Yep.
page 1, right?
Yep. Thank
Okay.
you. I'm sorry I missed that.
Okay. That brings us to consideration of 1427.
Do you want me to go through this, Senator?
Sure, if you would.
Okay, just making sure.
Mhm.
Okay, an act to encourage family care of aging adults. This bill prohibits the department from assessing a penalty on payments made to a family member providing personal support services within 5 years of a main care member who is applying for long-term care coverage. If the caregiver provided services but was not paid prior to the applicant applying for main care, that person's inheritance is exempt from the state's estate recovery in the amount equal to the fair market value of services provided. It directs the department to seek a waiver pursuant to 1915C to allow the provision of personal support services by a relative chosen by the recipient of services in a home setting. And it requires the department to amend its rules on eligibility for long-term care services provided under the main care program or state-funded programs to remove provisions and presumptions that disqualify some members from eligibility for long-term care. It removes the requirement for written agreements and presumptions regarding the purpose of paying for services and certain transfers, and it directs the department to adopt routine technical rules by to do that by October 15, 2022, and notify the committee of the completion of the rules. So you heard from the sponsor that he has 3 purposes to the bill. The first one is the applicant is presumed to have made a disqualifying transfer in the 5-year look-back period if they have paid a family member for personal care, and he's looking for a lower standard of proof there, encouraging family members to take care of their family member at home by allowing them to be paid for services. And as part of the main care application, the applicant can have a family member take care of them in lieu of a nursing facility, and allowing an exemption in estate recovery for the services rendered by a family member. Proponents, paying family members is common sense, but is assumed to be a transfer at less than fair market value, causing hardship, and we should be encouraging family members to take care of their own, taking care of family members at home, especially given the shortage of direct care staff, and the barriers are in the eligibility rule. The department, neither for nor against. Federal Medicaid law requires periods of ineligibility when an individual transfers assets for less than fair market value in the 5 years before application for Medicaid. The law requires proof of transfer for a purpose other than to qualify for Medicaid, and the department would not be able to do that under this bill. Personal care agreements are a common form of verification used by other states, and there is other documentation that can be used. The waiver exemption to estate recovery for personal care is limited to the member having an income less than 200% of FPL, and current policy requires the individual providing care must live in the home with the main care member for at least 2 years, and care-given exemptions are limited to 2 years before death or entering a facility. CMS is unlikely to agree to the restriction from those provisions that regarding the transfer of assets, and adjusting the poverty level may not be possible, and there would be a fiscal impact because more people would be able to claim the estate recovery. There are some drafting issues. There may need to be some clarification between reasonable services. Home care is less expensive
Then institutional care, value of services is based on a geographic equivalent, and I don't know if that's of home care, and also there's this fair market value. Does the relative providing care have to be an heir? That's really a technical question. I just don't know the answer. It's unclear what the language on lines 19 and 20 mean. This section is implemented by department staff in the department's application review procedures and in the estate recovery process. This is in relation to the changing the rules. If there is law and rule, I don't know why there is additional language about implementation being necessary. They have to follow law and rule. There's no provision in the bill for CMS approval for the estate recovery changes. There is language for the waiver for 1915C, but that's a different thing. This is the SPA, I guess, for estate recovery, and there's no provision for that in the bill. And so if it's denied, I assume that would mean this would come from general fund, but none of that is spelled out, and that's just something you would need to decide. Section 2 requires a waiver for 1915C. It's just unclear to me if that language is specific enough. There are a number of sections of main care that already allow for relatives to provide personal care and be paid for it. I don't know if there are members of main care who are unable to employ a relative now that are not prohibited by federal law or rule. In other words, I don't know what the population is I don't know if given federal law and rule prohibits certain situations in which relatives can take care of their family members, and that we have some sections where you are allowed to do that. I don't know if there's a gap between the two or not. I don't know if there's a group or not. That department would know that, but I have no idea. There's also no provision for what happens if that waiver request is denied. I don't know how estate recovery sections apply to state-funded programs, because that in line 36 it refers to state-funded programs. That's not referred to anywhere else in the bill, and I just don't know enough to know whether that's an issue or not. I just noticed that it wasn't anywhere else. And then section 3 states that the department may not presume ... for the purpose of qualifying for public benefits. It doesn't increase the types of evidence that may be used. And I don't know whether that means the department can't seek evidence regarding the proof of transfer, or just whether there needs to be some clarification of that language in terms of additional types of evidence to show that transfer was appropriate. And then it's also not clear to me if the current 200% FPL for the waiver exemption is still in place in the rules with the section 3 changes to the rules. You did have some questions. I don't know how many answers I have. We did ask the department why the changes were made to the hardship waiver for estate recovery. You got some, I'll get to that in a second, but you got some testimony about that. When can family members be paid now? And are there some this is relating to section 2. And that was what I just mentioned about. I don't know what's currently allowed and what's not prohibited, and what the gap is. There are certainly under section 19 and also 63, an adult receiving services can register as a personal care agency and hire their family members to provide care. Adult children can be employed to take care of parents or other family members, including siblings, under certain programs and state-funded programs, such as section 1963(12) and chapter 11. There are specific circumstances only in 96, which is private duty nursing, but they can't provide personal support services. I don't know the answer to why that would be, and I don't know what else there would be. And I understand that that section, the section with the waiver, is really about having family members take care of other family members so they don't have to go into an institution, and then the estate recovery piece is on top of that. So I realize that this is only a piece of it, but I just know there are some issues there. That's just a cross-reference for the notwithstanding, and then more cross-references because I think they're useful to see, because these are cited in section 2 with the personal care services and also the relatives as providers, and this is where we have the not prohibited by federal law or regulation language. And then this is the rule around fair market value. just as context, because these are the rules that would be changed by Section 3 of the bill. That was an overview if you were interested in looking at that. And then this is the question about why the rules were changed for the hardship. And you can see here, this is the markup version from when it was adopted, so you could see the difference. And this is what you had heard, that there was now a difference and it was more difficult to get the 32,000 exemption for a year. There were also some other levels, but the circumstances was, I mean, the testimony was that this had become harder to get the entire exemption. And then you also have I can't talk apparently, a memo from Molly. I don't know if you want to bring that up. I'm assuming you don't want me to read it to you, but I didn't know if you wanted me to bring it up while you were hearing from the department, but I can do that if you'd like.
Any questions based on that? That's a big bill. I'm not seeing any. Is that because we don't know where to start, or there are so many, or? So Molly, do you want to weigh in on any of the things that Anna flagged, or that would help us to know from the perspective of DHHS?
Sure, I do have the memo from the Office for Family Independence and Office of Main Care Services, and I'm happy to walk you through those questions and answers if that's helpful.
That
you want me to share it, Molly?
That would be great.
Okay, hang on a second. Okay, just tell me when to roll up, okay?
Okay. The first question was one that Anna referenced, which is who do we not cover right now? And I think that Representative Hassenfuss is likely trying to get at a different population, but currently people who are on Medicaid can have family members be paid for their services if they meet a certain some certain criteria. I believe the request is allow those family members to pay, or those potential main care members to pay their family members to do the services before they qualify for main care, without having that be held against them through in main care eligibility or perhaps a state recovery. And I think that is the part that we have federal guidance that does not allow us to sort of exempt that that expense if it is above fair market value. The second question was how we would make this change, and it would require a state plan amendment. But Main Care does note that we don't believe that less restrictive asset transfer rules would be approved by the federal government. And so while that would be the avenue to request that flexibility, we are not confident that we would receive it. There was a question in Representative Hassenfuss's testimony asking, or referencing, I should say, changes made to the hardship rules. And Main Care did want to make it clear that there are exemptions allowed, amounts allowed based on the level of care, which would have to be less than 24/7, and that policy is included. I will not walk you through that policy, but that change was made several years ago, and unfortunately, we've had some significant turnover since then. And so on the turnaround that we had, Main Care wasn't able to identify the specific date for that policy change. Well, that's a Main Care policy. And there was a question about what fair market value was, and yes, it appears the fair market value of the services would be compared to the facility services, not the cost of those provided in home. And so generally under these waiver services, what we're doing is assisting people, providing them services outside of institutional care. And so that's the comparison. There were a couple of questions from Main Care about whether the member would have to be nursing facility eligible when the family began to take care of them, or only when they went into the institution, and what the intent of the legislation was. They also noted, again, apologize, I'm trying to skim, so I'm not just reading you this paragraph, but there are significant challenges that they noted about assessing the value of care, and then making sure that care paid for prior to main care eligibility is of that fair market value, and also not a transfer of a larger size for another purpose. Regarding that may not presume language, we do interpret that to have us reduce the evidence requirement, which is what we are concerned would be against federal regulations. And so that is really repeating a concern that we highlighted above. And then there was a question about whether if a relative is providing personal care services at home and that is paid for by the main care member, but that relative is not an heir, is that still considered a transfer? And currently any relative can provide personal services as long as there's a legally enforceable agreement. In order to request a hardship exemption for estate recovery for personal services, the applicant must have a beneficial interest in that member's estate, which means, yes, that would likely be viewed as an heir, but to be precise, main care has offered the entire policy, which is another page or two. I'm happy to answer questions to the best of my ability. We have had some availability challenges with my colleagues in our offices, so I apologize that you're stuck with me, but happy to help.
Welcome, Representative Hassenfuss. Have you heard some of this conversation?
I have, Senator Claxton, and thank you all very much for taking the time to do this. Everybody's been working super hard, and it doesn't go unnoticed. And so thank you.
So there are certainly sections of this that bump up against the federal regulations, a number of those sections. So
yes, and if you'd like me to speak on that, the intent of the bill is in no way to go against the federal standards. The federal standards are minimum standards that the state needs to comply with. But the state has then, added higher thresholds. Like, so for instance, when we're talking about the evidence, the federal regulations just require that the transfer was not made to qualify for Medicaid. They don't set where that evidentiary burden has to be. So the clear and convincing evidence standard and the presumption that the department makes is easier for them, because they can, they can deny something if it doesn't have that really high threshold of evidence. This is saying part of this bill is saying we shouldn't require families to have such a high threshold of evidence. We should require them to have evidence, but let's go more with the preponderance of the evidence type standards, where they present their evidence, and if that evidence is more likely that this was not intended as a transfer than not, let's accept that. And let's not make it so hard for that presumption to be rebutted. I think what's really, really helpful is the testimony that was submitted by Mr. Delicata from Legal Services for the Elderly, because that walks it through it, and he lays out that, that 60-month penalty period. In no way is this bill trying to say that you can't make a transfer penalty for somebody who gave away a gift. We're not changing that. The intent is not to change that. the intent is to say that you can't presume that it was a gift if they can provide evidence that it was a, contractual exchange for fair market value. And they don't have to have a preemptive contract for that. They just have to provide evidence that what they did was done, in exchange for care. And if you look through Mr. Delicata's testimony, I don't know is he in the attendees?
No, he's not.
I can try to email and get him to be here, but he basically goes through the main care policy manual that deals with these aspects, which is in your written analysis from OPLA, which thank you very much for that. That was a great analysis there. And he kind of points to the third section in this bill where it has the rules, and it walks through and says that, the department, so for instance, where, services must be section I, 1.5 I of the rules. I'm on top of page 5 in his testimony says, the services must be performed after a written agreement has been executed between the applicant and provider. And then comment 5.1, from the proposed bill, it says the department may not require as a condition of eligibility that the applicant have a prospective legally enforceable written agreement governing the paid services provided by a relative. So that if that relative can get a different, can show that there was an agreement, even though it wasn't in writing, and they can show through a preponderance of the evidence that there was this agreement, then they will qualify. What this is designed to do is it's designed to protect that unsuspecting family that didn't go to see a lawyer before mom or dad or grandma or niece got sick. But there was a quid pro quo exchange where, Graham would pay $500 here or maybe $1,000 a week for services. And those exchanges were maybe documented, but there was never a contract. And if that family can provide evidence of that through an administrative hearing procedure, then I don't think the department should necessarily deny them and say, sorry, you don't have a written contract. So you need to pay that penalty period. Now, I'm rambling a little bit, so I'd like to bring it back to if you have any specific questions on this or on the different areas of the bill, because I know there's about 3 different aspects of this bill. But
You know of other states where there's no written contract requirement?
I think it's, now I don't know I can't list the states offhand, but I know that not every state does that. I'd say probably half the states have it, half the states don't. It's purely a state decision on how they want to implement that.
Okay. Are there other questions?
And if I may,
please.
I realize this is a big, complex bill, so I try to chunk it into pieces. So one piece is based on the rules. The last page of your OPLA testimony shows those rules with the transfers that we were just talking about. So one is payments made prior to applying for main care and what payments will be considered a transfer and what payments won't. That's one aspect of it. The other aspect of it, the section 2 of it, the waiver, that's requesting the department, and it could be through a waiver, it could be through a resolve. It's requesting the department to look at ways where we can encourage families to stay home and be paid by, main care. There are some ways now where they can do that by being, a care agency, and they have to set themselves up as essentially as a business or be employed by a business that provides care, and then they can get payments through that business. But it's a rather complex process, especially when you have a family who's really their only focus is to try to, keep mom or dad or whoever at home. And to add to all of this, they're putting through this application, and mom or dad might have dementia, and they don't know where all their bank statements are. They have a hard time finding those things. So section 2 kind of says, is there a way that we can develop a better process to have family members stay home, be given a stipend to care for their family members? And that might be workable within the current, the current structures, but by making things more accessible and, better publicized, or maybe, because of the nursing level of care that might be needed in some instances, maybe we would need to do a waiver to the federal government. And to answer the question is, any of this stuff, if it was determined by the federal government this does not apply, I wouldn't want to do it. I do not want to jeopardize receiving that aid from the federal government. And then the last section deals with estate recovery. It's my understanding that the state has to perform estate recovery outside of a few exceptions outlined by federal legislation. And it has to then, give that 2/3 ballpark figure to the federal government. But for the state share that the state pays for the Medicaid system, it can do what it wants with that. And my thought is that the exemption for, care provided and the exemption of estate recovery, if that care wasn't paid, would come out of the state's portion and not the federal government's portion. So it would have to be a percentage of the entire amount paid. And there'd have to be rules developed around that. But that's kind of the 10,000 feet look at this from that. And once again, I apologize that, this is coming on the 9th, the 11th hour with committees and all that stuff. And this is not a super easy bill by any stretch.
Does that prompt any questions, comments from the committee? Representative Craven.
Thank you, Mr. Chair. So I guess I'd like to go back to Molly and see, how doable is any of this?
The amendment proposal or the
Yes, any of the suggestions that the representative put forward?
Sure, I think with the caveat that I'd want to run them by Office for Family Independence, who does main care eligibility, but I certainly the clarity that we're not looking to be any more lenient than the federal government allows is certainly helpful. I think I'm not aware of whether we can divide up the state portion of what we recover through estate recovery, or what the regulations are around that. And so I would need to run that by our main care estate recovery folks.
Because I realize that this is a rather complex bill, I'm certainly happy to truncate it, to things that, if at the pleasure of the committee, if it does see that there's some areas of concern that I would like to address, I'm more than happy to work with the committee to, move this bill forward in any direction that it sees fit.
Yes, Representative Craven.
Yeah, so I'm a co-signer on this bill, and I wrestled some years ago with a very similar bill that didn't really go anywhere. And so I feel very guilty about getting up and saying that it is so complex and it's so late in the session that I would wonder if you would be willing to do something else with the bill.
Yes, I mean, given the circumstances of this bill in this year and everything that has happened, I completely understand where all of you are sitting, in that you would probably like to do something, and especially in terms of those who signed on as co-sponsors. And I understand that this is an issue that you would like to address, but you want to make sure that you have a quality bill, as we all do, and as I do. And so I am more than happy to work on it in any way possible. I'm not sure how, Representative Craven, how did your resolve to study, I can't remember the name of the LD, but it was the resolve to study in-home care. How did that vote in the committee? Has that been voted on yet?
Are you talking about this year?
Yes.
Yeah, it was a unanimous vote out of the committee and I just got an alert from Mark Sear today with no.
Yeah. So
it's going forward.
These two issues kind of really cross-sect quite a bit. And I was kind of hoping the work sessions would be together, and so maybe we could combine different aspects of it. And that bill has a report out for another bill. Representative Craven, is that correct with that?
Yeah, we have permission to report out a bill after the study.
Yeah. And I'm new. I don't know how hard it would be, but I'm wondering if some of these questions, especially if the committee is intrigued and says, I'm intrigued by these aspects or these particular things, and I'd like to do something, but I'm not really sure if this bill is ready to do it at this point. If something like that could be incorporated with that study, so that when a bill gets reported out next year, it might include some of these very issues. I think that would be, I would be more than happy with that.
I think that it was the ombudsman that had suggested the bill years ago, and she's very, very familiar with all of this. And I would suggest that you would talk to her about it. She's going to be leading the study.
Yes, and I've spoke with her about this bill early on, and her recommendation kind of was, to see if there's something that we could study with this. I'm not sure. I think it would be helpful to have some direction with the committee that included, with that study, that the committee would also like to visit any of these issues on here. I'm not sure procedurally if that's possible. And I'm not sure if this would necessitate its own, resolve to study these issues separately from that. I think these easily could be kind of combined into one. I think that's a good route, but that may require, a motion to reconsider from the committee and all new votes on that last bill. I'm not sure, or I'm happy to have this be, some sort of resolve with a report back next year to see if any of these can be addressed in a sensible way that's not going to jeopardize federal funding and can, accomplish what it hopes to.
Representative Perry?
Yes, this is late in the day too. My mind is not really working very well. But in looking at this, I don't see why, because this is very complicated. I was going to ask a whole lot of questions that would have to come back and stuff, and we don't have the time to go back and forth on this. So what I was wondering that we could do is actually write a letter to the department, and I know people don't like letters, asking them to put these issues into the ongoing study that Representative Craven's bill had brought forth, so that we can do that as an addendum without having to recall legislation and all of that, and let this bill go.
So we could certainly send that's a similar sort of letter to the ombudsman saying this issue came up in committee. What can we do of the content of the bill that would help promote the family providing care? That should be part of what the family caretakers need or caregivers need.
Yeah, I mean, I think that would be a very reasonable request. Yeah, I think that works, and as long as everybody on there understands that, and of course it would be up to the committee to decide how it wants to do that. But if it understands that there was this other bill that was very similar, but it's a very complex bill, I will be the first to admit that it's a very complex bill, and it probably would need a couple of work sessions, which we just don't have time for at this late stage. And if they got the message that included in the study that you've put the resolve for, that you'd also like them to look at these issues, then I think that's a great way to sort of keep this bill alive, knowing that next year, if these are issues that this committee would like to address, and I'm more than happy to follow up and continue discussions with this committee, that those can be part of that bill that's reported out of this committee for, ways to encourage family care of aging adults.
Representative Craven, did your bill that goes to that the long-term ombudsman is going to coordinate, that include a report back and an option to do legislation?
Yes.
Yeah, so that would be an obvious place. So if we got this information to her and said these are some of the issues, or this is an attempt on the legal side to try and address some of these issues, that could be included probably at a higher level, and then we could refine it into something more manageable come the report back. Representative Perry?
I was just going to move ought not to pass with a letter going to the ombudsman about including these issues in the study.
I'll second the motion.
Thank you. Anna, do you need some more clarity before you write a letter, or?
I just want to ask a question. Is this the bill that requires the long-term care ombudsman to work on an assessment tool? Because that was a very specific study. Is that the bill we're talking about?
I thought there was a bill to assess what caregivers need.
Yes, it was. It's about developing an assessment tool. And
Okay.
they were looking at the T-Care or whatever it was called, the assessment tool in Washington.
Right.
I'm just struggling to figure out exactly how this fits within that bill. I'm happy to write any letter to anybody you like, including Brenda. I'm always happy to talk to Brenda. I'm just trying to struggle to how this fits in with that. I'm just worried that after you all decide this letter that it's related to Representative Craven's bill, and it isn't, that then you're not left with anything. And I'm just a little concerned about that.
Well, if the broadest question for Representative Craven's bill is what do family caregivers need, this would fall into that category. And maybe they just need to be specific about, is it going to make a difference to your family if one of your members requires care in the 5 years before they go to main care? Are there legal issues that we should know about? I think at least to be part of the conversation that goes into creating the questionnaire. I think that's a reasonable inclusion. And we can also put it on the radar. I'll go to Molly. I assume that some of these issues are issues that the department's talking about every once in a while, or that comes up in main care to try and how to make this work best for Mainers.
Sure, and I think that regardless of flexibilities that we may or may not have in main care, supporting family caregivers and the way that supports people aging at home and keeps people from institutionalized care is something that the Office of Aging and Disability Services spends a lot of time on.
Okay. Okay. So have they seen this particular bill?
I don't believe, not through me, that was Maine Care and Family Independence, but I can share this with Paul and his team and make sure that it's on their radar as well.
And maybe Representative Hassenfuss can use the feedback from Anna to likely cross out or make likely to be removed any portions that are going to bump up against federal regulation. And therefore, we'd have a smaller bill to consider.
Yeah. I think I can take that time to, get the language, kind of worked out. This was a first draft, and essentially the next one will be a second draft. I think my only concern is just making sure that this request does fit within that resolve, which I wasn't privy to what that resolve actually said.
Sure.
But and I would imagine that this committee has the power to draft the bill based on that resolve.
We retain the right to create legislation when we get a report back from the ombudsman.
Yeah, and so I would imagine anything in here could be included in that if the committee so chooses, correct?
Sure, if it's a part of a suggestion, from that office, from that report. Representative Perry?
Yeah, I was just thinking the other thing that we could do is send a letter to Molly and she'll get it to the right place. I don't know where to send it to, but really for that group that is looking at home care, in Medicaid, and review some of the suggestions in the bill and see if this is something, that they can do without having to have legislation for it, and get back to us.
Sounds good to me. We just created some work for Molly, but it sounds good to me. All right. So at this point, we're thinking that this could be information that could be provided to the long-term care ombudsman for consideration in the study that came out of, will be coming out of Representative Craven's bill. And that would leave us some option for language review. We could also send this to Molly for some feedback from the OFI folks and Maine Care about if there is some additional opportunities for flexibility that we haven't recognized. Does that sound like a way forward, folks? I see some head nodding. Okay. So Representative Hassenfuss, that would get it to the department and to the long-term care ombudsman, two different sets of eyes on this to see if there are elements of this that deserve more development.
Yeah, and I think that's possible, especially given that this committee will have the ability to review any of those thoughts and report out a bill that may incorporate some of this, all of it, or none of it, depending on what the stakeholders have to say.
Okay, so with that understanding, I'd entertain a motion ought not to pass with the content of this and the letter to go to Molly and to the long-term ombudsman.
We already have the motion.
That motion.
Yeah, okay. Yeah, I'm sorry, thank you. What makes you think I'm tired? So moved, seconded. And then we can go ahead and have Carrie collect the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 9 yes, 4 absent.
So thank you for bringing this forward. I think it's a early and dense first step, but if we can get a little further down the road with some other inputs and some other outside eyes, then we can maybe extract from it some particularly salient pieces for where you're headed.
Thank you very much, Senator Claxton and Representative Myers and all of the honorable members of the HHS committee. And I just want to say thank you all so much. I know you've been going 5 days a week, 9 to 5. You've got so many bills in front of you. It doesn't go unnoticed, and keep up the good work. We're almost through it, and have a wonderful afternoon.
Thank you. Take care. So I think we learned earlier that there wasn't any additional work to come before the committee this afternoon. I think Anna acknowledged that. And the cover letters we're talking about can be pretty simple on top of the bill itself after we get it marked up, get it back from him marked up with exclusions for parts that really we don't want to go with there. Any other comments? Any other business?
I'll make a motion to adjourn.
Second. All those in favor of adjourning until Tuesday.